Good morning. Is the audio working okay? Yeah, okay. No, I should speak louder. We're good? Okay. Good morning, everyone. I am Zahra Sadat. I'm one of the epileptologists here at Stanford, and my practice is largely at the Stanford Pleasanton campus. So we want to welcome everyone to Stanford's campus in the East Bay. This is just one of the buildings, but the Stanford Tri-Valley campus is very close by. So many of the epileptologists here today primarily have their practice at the Pleasanton campus, and it's a relatively new campus. So I'm just gonna put a little plug for Stanford Pleasanton. We have a comprehensive neurology clinic. We also have 3 epilepsy specialists, and we are going to be opening an epilepsy monitoring unit in August of 2021. That tends to be very convenient for people coming from the Central Valley or east of the Bay. So I'll introduce our faculty who are at the Stanford Tri-Valley Clinic. Dr. Roberts did 2 years of epilepsy fellowship at NYU. He's standing up in the back of the room over there. He joined us within the last year, and we're very excited to have him. Thanks, Zach. Thanks for being here. He has special expertise in treating patients who have complex epilepsy and doing neurostimulation. And we will all be happy to see you at our Pleasanton campus. Dr. Zhang couldn't be here today because she's traveling. She has been at the Pleasanton campus for the longest, so she's the most senior at our campus here. She did her epilepsy training at UCLA, and she has special interest in treating patients who have epilepsy and also patients who had stroke leading to epilepsy. And I did my epilepsy training at Stanford, and my research was in cognition in relation to epilepsy medications and epilepsy itself. Today, we're also joined by our colleagues who practice in Emeryville and Palo Alto. Dr. Samudra is also sitting in the back. We're very happy that she joined our team. She works in Emeryville and Palo Alto. She has 2 fellowships, one in behavioral and cognitive neurology, which she got at UCSF, and one in epilepsy, which she got at Vanderbilt University. She has special interests in treating patients who have both epilepsy and cognitive disorders, and we're very happy that she's here. Dr. Fisher, it's an honor to have Dr. Fisher with us today. He's at the back as well. He's the director of the Epilepsy Center at Stanford. Most of you probably know him already. He has more than 100 publications, has written 4 books, has been the president of the American Epilepsy Society. So we're very honored to have him here with us today. And then Dr. Buch is our neurosurgeon. He's in the back. We're very thankful that you could join us today. Dr. Buch specializes in epilepsy surgery, as well as stereotactic and functional neurosurgery, among other things. He has also published many articles in the most renowned neurosurgery and neurology journals, and also holds patents in the areas of artificial intelligence relating to neurosurgery and neurostimulation. So thanks for being with us. We are all very happy to have all of you here today and hope that we can help in your care. Thank you.
All right, I can hear the mic is working. Hi, everyone. Do we have my slides? No. If you have any questions. Yeah, of course. Oh, oh, we have a clicker and everything. Very cool. All right. Let's see. All right, simple enough. Hi, all. My name is, I guess, Dr. Zach Roberts. I'm Zach. As Dr. Sadat so nicely said, I am one of the new attendings out here at the Stanford Tri-Valley campus. I am epilepsy trained. I did my training over at NYU before coming out here. Very excited to be here today. Very excited to have you guys all here. I think we have a nice range of talks to give for the next few hours. I'll be leading off and I'll be starting with an overview of seizures and epilepsy. And if anyone has any questions, I guess we can do hand raising work. Raise your hands and I'll be happy to take questions. So this will be Epilepsy 101. And before we talk about epilepsy, we should talk about seizures. So what is a seizure? There's many different ways we can define seizures, but perhaps the most simple definition I can give is that a seizure is an electrical storm in the brain. The brain, like basically most of the world at this point, runs on electricity, and a seizure is when that electrical network goes haywire. As a more technical definition, a seizure is abnormal firing, typically excess firing and repetitive firing of brain cells or neurons, which cause neurological symptoms. And as we'll find out and hear about during this talk, there's many, many different symptoms of a seizure, but usually when people think of seizures, they think of symptoms like this. So people can become unresponsive during seizures or become confused. Certainly, we see a lot of abnormal movements, such as tonic-clonic activity. We can also see hallucinations, visual, auditory, tactile as well. There could be cognitive symptoms of seizures, such as déjà vu being one of the more famous ones. And then finally, of course, seizures can involve convulsions. And while most people out there think seizures are this rare, terrible thing that the brain does, turns out seizures are actually a lot more common than people think. About 1 in 10 people, so 10% of the population, will have at least one seizure during their lifetime. So there are, of course, many, many different types of seizures, and perhaps the most important categorization of seizures is the difference between generalized seizures and focal seizures. And what does that mean? So with the generalized seizure, that means that the seizure starts everywhere in the brain all at the same time. And that is, in fact, what we see on EEG. If we're looking at the recording, we see that those discharges and that rhythmic slowing seems to start everywhere. It's everywhere all over the page, and it all starts around the same time. By contrast, focal seizures tend to start, or they will start, in one specific area of the brain, and then, of course, may spread. And in fact, they can spread to involve the entire brain in a process that we refer to as secondary generalization. And of course, there are many, many different types of both focal and generalized seizures. So starting with the generalized seizures, when we talk about these types of seizures, we like to talk about, and we classify them by the different types of motor phenomena, so the movements we see with these seizures. So there are atonic seizures. This is when the patient loses all tone in their body, and this usually causes them to fall, which is why they are often referred to as drop attacks. We also have myoclonic seizures, and that involves rapid jerking of the arms or legs. Tonic seizures, which involve stiffening of the extremities, usually both arms and both legs. We also have clonic seizures, which are very similar to myoclonic seizures in that they involve jerking of the limbs, the arms and legs. With clonic seizures, though, it tends to be more repetitive and rhythmic. We can, of course, get combinations of these different types of movements, the most famous of which being the tonic-clonic seizure. So this involves stiffening of the arms and legs usually, followed by rhythmic shaking. And there's many different names for this. So when tonic-clonic seizures generalize, we do refer to them as generalized tonic-clonic seizures, or GTCs. An older name for this is the grand mal seizure. And we're moving away from that terminology, but you'll still hear it used a lot. And then a more simple term for this is, of course, simply just a convulsion. So you'll note that all of the seizures I've talked about have involved different types of movement or motor activity. There is a form of non-motor generalized seizure that tends to be actually pretty well known. That's the absence seizure. So this is a seizure that is characterized primarily by staring spells. Sometimes there can be little movements of the arms and legs, but the primary feature is that it's actually non-motor. The old name for the absence seizure, in contrast to our grand mal seizures, is the petit mal seizure. So grand mal being large, petit meaning small. With focal seizures, sorry, a little loud there. Apologies. With focal seizures, we tend to subclassify them based on their effect on the level of consciousness during the seizure. So we have focal aware seizures and focal impaired awareness seizures. And as you might have guessed, with focal aware seizures, what that means is that there's no alteration of consciousness. There's no confusion or unresponsiveness during the seizure. By contrast with focal impaired awareness seizures, there is alteration in consciousness. There's confusion or unresponsiveness that happens at some point during the seizure. And it's important to note that it doesn't have to be during the entire seizure. And in fact, if you've heard the term aura when it applied to seizures, so a seizure aura usually refers to the symptoms of a seizure that occur before the patient loses consciousness or becomes confused. Now, in the spirit of giving the old names for things, since you're still going to hear them said around the clinic and in the hospital, focal aware seizures used to be called simple partial seizures, and focal impaired awareness seizures used to be our complex partial seizures. Oh, yeah.
In terminology.
That is a good question. I think right. Sorry, getting used to this. So the question was why the change in terminology? And I think we have an answer from Dr. Fisher in the back of the room. So I will hand things over to him.
You can blame me. I was chair of the International League Committee that upgraded the terminology. Almost nobody knew what complex partial seizures meant. And it was offensive to some patient calling seizures simple anything, because you know better than I do that even if you don't black out with a seizure, it can still screw up your life in a very non-simple way. And the whole concept of consciousness, when people aren't like blacked out and lying on the floor, it didn't make a lot of sense to people to say that they had lost consciousness when they were walking around the room, fumbling, smacking lips, like a lot of people did during the old complex partial seizures. So we just tried to clean up the terminology and not really change the scheme, but give names that were a little bit more transparent. And then there also were some seizure types that weren't included. So those were thrown in. And I think most people, at least the doctor side of things, are coming around to accept the new classification. Nobody likes it when you change the names for things. I had to go into the witness protection program for a while, but I've come out now. Thank you.
Thank you, Dr. Fisher. Yes, we're trying to move towards using the new terms because, as Dr. Fisher said, they're more accurate terms for these types of seizures. But old habits do die hard. So I like to bring up the old names just so everybody is on the same page. Now, moving back to our focal seizures, so you'll recall we have our focal aware and focal impaired awareness seizures. When it comes to the symptoms of focal seizures, there's actually a lot of different symptoms. In fact, almost an infinite number of symptoms because focal seizures happen in certain areas of the brain, and thus the symptoms of those seizures is going to depend on where in the brain the seizure is happening. So if you see this graphic on the slide here, we've labeled the lobes of the brain here. So starting with the frontal lobe in this nice, I don't think I have a pointer actually, but this nice sort of blue-purple color. So the frontal lobe is involved with producing language, behavior, judgment, and decision-making, as well as motor activity. And thus seizures that are taking place in the frontal lobe or involve the frontal lobe will often present with difficulties in speech, changes in behavior, as well as, of course, a lot of the motor phenomena that we discussed. So when we think about tonic events and clonic events, usually we're thinking that that involves the frontal lobe. As we move back, we have the parietal lobe, which is in that nice gold color there. The parietal lobe is one of our sensory processing areas of the brain, mostly dealing with tactile stimulation. So that's the sense of touch. So seizures that are occurring or involve the parietal lobe can present with changes in sensation. So you might feel warmth or coolness of a limb or numbness and tingling traveling up or down a limb. That can be a sign of parietal lobe involvement. As we keep moving back, we have the occipital lobe in the back of the brain. That's our visual processing center. So seizures that involve the occipital lobe can, as I'm sure you're sort of picking up here, involve visual symptoms. So these can be very simple ones, such as flashing lights or certain colors. They can also be somewhat more well-formed, so more complex shapes and images can be seen. Finally, we have the temporal lobe, and the temporal lobe is very important when we're talking about epilepsy, as mesial temporal epilepsy is a common form of adult onset epilepsy. So the structures in the mesial temporal lobe, there's many of them, but the two major ones we like to think about are the hippocampus, which is involved in memory processing, as well as the amygdala, which is involved in emotional control. So when seizures involve these structures, we see symptoms related to memory, such as déjà vu, or emotion like fear or anxiety. And the lateral part of the temporal lobe, that's the part of the temporal lobe that is closest to the skull. It's the part that you can actually see on the slide here. That's where we have auditory processing. So seizures in that lateral temporal lobe can present with hearing changes and auditory hallucinations. Now seems like as good a time as any to bring up one of my favorite pieces of advice that I received when I was training in epilepsy, which is that because seizures come from the brain, pretty much anything the brain can do, a seizure can do as well. There are some exceptions to that, of course, but the basic principle remains true. And that's why there are many, many different types of seizures out there. And, basically there's no single type of seizure that will describe all patients. And I think we have a question. Oh, no. Okay. Not a problem. All right. So moving back to this slide, so one important point to bring up is that the symptoms we just spoke about on that last slide here, it's sort of independent of the level of consciousness. So with both focal aware seizures and focal impaired awareness seizures, we can see these motor changes, these sensory symptoms. It's also important to highlight that both of these types of seizures can progress to convulsive activity. So they can secondarily generalize, and they can look a lot like our generalized tonic-clonic seizures at that stage. So moving on. So what causes seizures? There's, again, a lot of different answers to this question. And we have a question from Dr. Fisher.
Explain, what a typical temporal lobe seizure looks like in the most common seizure type, because a lot of even doctors don't recognize that it's seizure.
So the question was asking me to describe a typical temporal lobe seizure, which, as Dr. Fisher highlights, is a very common form of seizure. So the typical temporal lobe seizure, in a lot of ways, can look a lot like absence seizures in that there can be behavioral arrest, typically with some automatisms like those subtle chewing movements or movements of the hand. Automatisms is another motor phenomena that we see with epilepsy, which describes more complex movements that are still non-purposeful. So we can see sort of behavioral arrest, automatisms usually with the mouth and the hand. Often patients will report a rising sensation in the gut, which is a sort of autonomic symptom that I've heard described as feeling like you're going over a roller coaster. And then, of course, déjà vu can be part of that as well. And that's usually attributed to involvement of the hippocampus. So that collection of symptoms, not all of them have to be present, but can be very suggestive of a mesial temporal seizure. Mesial just being a fancy term meaning middle of the temporal lobe. These seizures can, of course, progress so that you can see other symptoms with them, and they can spread and, again, become what we call focal to bilateral tonic-clonic seizures. So it can start with those very focal symptoms and then spread and have more general symptoms.
It would be common that someone might have those, a child might have those for years before anyone actually recognizes that it's a seizure. And then finally, when it spreads,
Good luck.
and you get the generalized tonic-clonic, which used to be called.
Yeah, it should be the right answer.
And that's an excellent point Dr. Fisher makes there. I don't think you're on microphone there. But yeah, these seizures can be subtle, both, temporal lobe seizures as well as actually absence seizures, because they can be somewhat unimpressive in a way. They just look like staring and a little bit of twitching, and then they're over. So they can be misdiagnosed and missed for years, is what Dr. Fisher was saying, until they perhaps become secondarily generalized and they present like the typical convulsion that people think about when they think about seizures. So where was I? Oh, we were going to talk about causes of seizures. So one helpful way to think about the different causes of seizures is to go across the age span. So there are different causes that we think about depending on the age that a patient comes in with seizures. So when we're talking about pediatric patients, so our children, we think about seizures that might have been caused by birth trauma or injury to the brain during the birthing process. Fevers and infection can be triggers of seizures in younger children. Certain genetic syndromes, metabolic conditions, immune and autoimmune diseases can also be causes of seizures. As we grow older, we certainly see patients in adulthood who still have seizures related to birth trauma and genetic conditions. But when new seizures occur in adults, we think about certain other conditions. So certainly head trauma can happen in children, but it's a little more common as we get older. We hope that we don't see drugs and alcohol causing seizures in our children, but certainly we can see that in adults. Infections can still be a cause of seizures. And as I've mentioned, mesial temporal sclerosis can cause that mesial temporal epilepsy. And sclerosis is just a fancy word that means scarring. So scarring of the middle of the temporal lobe is a common cause of seizures in adults. And of course, there's a lot of overlap as well. So metabolic conditions can still cause seizures in adults, immune diseases, infections, particularly if they involve the brain. As we get older, again, we can still see some of the same causes we see in younger patients, but as we get older, when we see, the elderly coming in with new seizures, we tend to think of the kinds of conditions that cause brain injury in older adults. So this will include, of course, tumors, strokes, trauma can still be a big one, dementia can be a cause of seizures, and then, of course, there's still that overlap. And you'll forgive me one second, I gotta take a drink. Good time for me to take a question.
Why it would affect an adult, but not the child.
It still could.
So it says that metabolic conditions and immune diseases are all for children, adults, and elderly.
Mhm.
Could you give an example of why it might affect as an adult, but not as a child, or why it would affect you as when you are elderly in age, but not when you are an adult?
So that's, I think, more an error in the terminology I'm using. It depends on what we mean. So there's certainly like inborn errors of metabolism that cause seizures that usually present in childhood and certainly not necessarily when they become adults because that error was already there. But metabolic conditions is also sort of a catch-all term that I'm using. So, for example, low blood sugar is a metabolic condition in this case. And, babies with hypoglycemia can have seizures, as can adults and the elderly. So I think that was a sort of an error because I was using it as a catch-all term there. Different types of metabolic conditions, the inborn ones, typically related to genetic syndromes, cause seizures, and typically those present in childhood. But metabolic conditions can also encompass sort of electrolyte abnormalities, low blood sugar, things like that. And that can provoke seizures at any stage in life. And it's similar with immune conditions. It depends on the different type of immune condition, because some present in childhood, other ones present later in life. That makes sense? Yeah, not a problem. All right.
I think I read something a while back about shingles primarily located, having
Mhm.
possibility of that affecting temporal. Has anything come of that, or it was a while ago that I read something about shingles and epilepsy, especially in older adults.
So the virus that can cause shingles, which is the virus that causes chickenpox, can certainly present with that outbreak as you described on half of the face or half the body. There's a different form of infection when that type of infection, that varicella virus, is actively infecting, for example, the temporal lobe, that can produce seizures. In terms of, like if you have shingles, does that put you at risk? It's a good question. Well, when you have shingles, it does mean that the virus is still inside your body, and theoretically, it could then also present in the brain, but we don't necessarily think of shingles as a risk factor for definitely getting that infection in the brain. It's very, very rare to see that infection actually occur in the brain. It's a possibility, but generally when it represents, because it lives dormant in the body, it represents in what is thankfully a benign or more benign, but certainly painful condition, which is the rash that people develop with shingles. And we very much hope that it does not represent with brain infection. All right. And we have another question. Sorry, and I don't know anyone's name here, or I'd be calling on people, except for my colleagues. I know their names, most of them. All right.
Watching too much.
Can watching too much TV shows over your course of your childhood cause seizures?
I wouldn't think so, no. There are, of course, the very famous cases in patients that have photosensitive epilepsy where certain episodes of television, most notably, I think there was a Pokemon episode that never aired in the States because it caused several hundred Japanese children to have
I
seizures.
believe that infamous episode got banned worldwide,
Yeah, exactly.
including Japan.
Yeah, I think the first time it aired, yeah, there was a segment where I think there was like 15 straight seconds of just flashing screens, and that can be a trigger for seizures in patients that have photosensitive epilepsy. That's not all that common amongst epilepsy, but it's certainly a risk factor. And after incidents like that, they did make laws about how you can animate television shows and or give warnings if there are flashing lights. However, to my knowledge, I don't believe that just watching television in general would increase your risk of having seizures later in life. That's a very good question. Oh, and we have another one.
Doctor, I think I don't need the mic. I don't think.
It's-
I noticed when my teenage son had his first seizure, and then as I got older, or as it happened, a lot of other people were saying, "Oh, my teen had the same thing. Oh, mine too." Is there something specific in teenagers that would cause that? Because through his childhood, nothing appeared to be, and then all of a sudden he had one.
That's a tricky question because there certainly are, sort of as I touched on before, there are certain epilepsy syndromes that just don't present for whatever reason until teenage years. It also, of course, depends on the type of seizure we're talking about. For example, if we're talking about like mesial temporal seizures or absence seizures, where they just present as like staring spells, it could be that you happen to be in touch with a lot of people, parents who have children that also have that type of seizure, but because they look like staring spells in teenage years, that could also be non-seizure activity. And it just so happens to be that teenagers are the type of people. I remember being one, it was not that long ago, yeah, who like to daydream, sometimes zone out. And that actually can be a diagnostic challenge for us because, like sort of a classic board question for us is the child that comes in, they're staring in class, everybody thinks they have ADHD, but stimulants aren't working for them. And it turns out that that's because those zoning out episodes are not related to attentional issues. They're related to seizure activity. So it sort of depends on the type of seizure we're talking about, but there are certainly types of epilepsy syndromes that do sort of present. Oh, I'm getting flagged in the back. Or how are we doing on time?
We're doing well.
Okay.
But there's a question.
I was asked
Oh,
to
okay.
repeat a question on Zoom. Can Ehlers-Danlos syndrome cause seizures? Those who don't know, Ehlers-Danlos is hyperflexibility of the joints. People are often tall and slender. It sometimes has associated heart problems. It doesn't normally get associated with seizures, except for a rare genetic variant that has what's called abnormal nests of cells in the brain, also dysplasias. For the most part, Ehlers-Danlos, I would say 99+% of people with that don't have seizures.
Thank you, Dr. Fisher. And I think we have one more question, or we might have more than one question.
Kind of piggybacking off of what this gentleman asked, is there enough evidence to show that hormones may affect as a cause of seizure? Or if there are enough?
That's a very good question as well. And, without being able to necessarily cite a lot of literature, we do know that in general, hormones can play a role in how epilepsy presents. I don't know about necessarily being the cause of epilepsy, although certainly, there's certain hormone conditions where you end up with seizures because that also affects, how much sodium is in your body or your blood sugar. We also know that there are forms of epilepsy that do vary with hormones. So catamenial epilepsy refers to epilepsy that tends to occur at the time of someone's period. So of course we see this exclusively in women, but we know that certain people are at higher risk of having seizures during certain parts of the menstrual cycle, which tells us that there is at least some role of hormones in either preventing or allowing seizures to occur, depending on which hormone is building up at which time.
Thank you.
Yeah, no problem. Let's see, where was I? Any other questions? I think I was going to keep talking about causes of seizures. So another way to look at different causes of seizures is by looking at what we call provoked and unprovoked seizures. So provoked seizures are seizures that are typically caused by an identifiable and reversible problem. And this is sort of what I was hinting at the last slide when we talk about metabolic conditions. So different things that can provoke seizures can be things like metabolic abnormalities, whether it's, I've mentioned low glucose, hypoglycemia, low oxygen, hypoxia. Many different electrolyte abnormalities can provoke seizures as well. One of the more common ones being low sodium levels. We see seizures that are provoked both by alcohol intoxication as well as withdrawal. There are other drugs of abuse that can cause seizures with withdrawal, most notably are benzodiazepines. There are also certain medications that can cause seizure in overdose, with a notable example being some of our antidepressants. Let's see, recent brain injuries can provoke seizures. And then as a special case in children, we can see seizures that present in the setting of fever, what we call febrile seizures. The important thing about provoked seizures is the idea is once we get rid of that provoking factor, once we correct the sodium, fix the glucose, restore oxygen, get someone out of that withdrawal period, the idea is those seizures wouldn't come back. So they only occurred because of that provoking stimulus. And the good thing about that is it means that there isn't a high risk of seizures returning unless they, again, become hypoglycemic or hypoxic, et cetera. By contrast, our unprovoked seizures are either seizures caused by a permanent problem, so a permanent injury to the brain that can't be gotten rid of, or that happen without any clear provoking cause. And it turns out that this distinction is very important because it's the unprovoked seizures that lead to someone being diagnosed with epilepsy. In fact, the simplest definition I can give for epilepsy is basically having a brain that is predisposed to having recurrent unprovoked seizures. So there are, of course, more specific diagnostic criteria for diagnosing epilepsy, most simple of which is the one that I've listed at the top of the slide. This is having 2 unprovoked seizures more than a day apart, more than 24 hours apart, is diagnostic of epilepsy. Now, you don't need to have 2 seizures to get a diagnosis of epilepsy. So if you have a single unprovoked seizure, but our workup shows that you have a higher than normal chance of having more seizures in the future, we set that cutoff at about 2/3, 66% risk of having another seizure. That is also diagnostic of epilepsy. Now, there's a lot of different ways we can figure that out, but in most simple terms, that typically means having an abnormal MRI, abnormal imaging, or abnormal EEG findings. Now, forgive me 1 second, I do need to take a sip of water. Now, finally, it is technically possible to get a diagnosis of epilepsy with no known seizures. This is, and we don't see this very often, but if we do a workup and we find findings on exam or on genetic screening that essentially guarantees 100% chance that you'll have seizures in the future, we can make a diagnosis of epilepsy in that context. It is, of course, very rare and almost exclusively seen in the pediatric population for somewhat obvious reasons. Usually those seizures will happen sooner rather than later. I believe we had a question.
Am I on? Okay. So when someone presents with certain symptoms, either what they experience on the inside or say the behaviors on the outside, is that when it would be more likely, besides genetics, to diagnose without say, a test result?
Well, so I don't know that there's any instance in which we would diagnose without a test result. The instance that you're referring to, frequently, if we're going to make an epilepsy diagnosis, those feelings that people have, which can be non-visible, often if we're making a diagnosis of epilepsy, that's likely because we believe that those symptoms are reflective of seizures. Because remember, seizures can sort of do almost anything. So it's not just the obvious, motor seizures with tonic-clonic jerking. If, certain subjective experiences, if they sound seizure-like, and of course, there's a lot we could talk about there. Often, if we're making a diagnosis of epilepsy, it's because we hear those symptoms and we say, that sounds actually exactly like, for example, a mesial temporal seizure, even though it might not be recognized as such, because, of course, déjà vu is a common phenomenon. Having sort of, chewing movements is something that can be easily confused with something purposeful. And that's when sort of actually I think the next slide, did I lose my clicker? No, I put it in my pocket. Next slide sort of talked about, the next slide is just showing the stat, but it talks about the idea that part of diagnosing epilepsy is it's more complex than this. It's very rare that a patient's going to come to our office and say, listen, doctor, I had one seizure yesterday and it, just so happens more than 24 hours ago, I also had an unprovoked seizure. And then we say, bam, of course, that's epilepsy. It's rarely that simple. So taking a very thorough history is actually one of the most important parts of diagnosing really any condition, including epilepsy. I believe I had another question. Yes. And how are we? Forgive me, I'll look at my phone to figure out. Okay, got like 5-ish more minutes. Okay.
Why do they have to be more than 24 hours apart?
So
Because the prognosis is the same. If you have two seizures on one day, it's the same outcome 5 years down the road as if you have just one.
So what Dr. Fisher had said is basically if the two seizures occur within 24 hours, what the data shows is that does not necessarily increase risk of seizure in the future, more so than the general population. So remember, I guess this slide becomes relevant. 1 in 10 people will have a seizure during their life. So if you have 2 in the same day, what the data shows is that does not necessarily mean that you have a higher than that normal rate of having another seizure in your life. If they're more than 24 hours apart, the data shows that the likelihood is you're going to keep having seizures. And I think part of that is because we know seizures can cluster. So having them back to back in the same day, we still count that sort of as one event. But yeah, eventually it comes down to the data. The data has just shown that if they're in the same day, same 24-hour period, it does not necessarily increase the risk in the future. But if they're more than 24 hours apart, it does increase that risk above that 2/3 or 66% chance that you will continue to have unprovoked seizures. So I've got the slide. So remember this stat, of course, from earlier in the talk. So 1 in 10 people will have a seizure during their lifetime. Epilepsy is actually still, it's much less common than having just a single seizure, but it is still fairly common. So 1 in 100 people will go on to have a diagnosis of epilepsy. So I think I've talked a lot about sort of how we diagnose epilepsy based on history. We, of course, use a physical exam. Imaging of the brain is very crucial to this to figure out if there is some lesion that could trigger more seizures in the future. Almost everyone with the diagnosis of epilepsy, in fact, basically everyone will get an MRI of the brain. The EEG I'll try to talk about in a little more detail on the next slide. And then you'll note that a lot of the labs I've listed are actually mostly there to look for provoking causes of seizures, to look and see if someone comes in with a seizure, is it simply explained by low blood glucose or hypoxia or things like that. So we're trying to figure out if it was a provoked or unprovoked event. Talking a little bit more about the different types of EEG, and perhaps I'll just click through so we have all 3 of them up there in the interest of time. So you've probably heard of routine EEGs, ambulatory EEGs, and then continuous EEG. And I wanted to take a couple of minutes to distinguish between the 3 of them. So the routine EEG is probably the most common one that we see ordered. It has the most utility. It's the most flexible, if you will. So routine EEGs can be done in the clinic, but they can also be done in the emergency department and while people are admitted to the hospital. They include video, and the one drawback, if you will, of them is that they tend to be shorter. So we get less data with a routine EEG. There's no set time. Typically, they're 30 minutes to an hour. I've seen up to 2 hours, but beyond that, we would typically consider it continuous. The ambulatory EEG, the primary benefit of that EEG is that we get a lot of data. So typically it's 24 to 72 hours of recording. The other big benefit is, other than coming in to get the EEG placed, you can then go home with the EEG. Now that is tied to the drawback, which is used to be that there was no video that came with ambulatory EEG. Nowadays, there are some companies out there that do at-home video, but it's still very rare. The other issue is, because you're home with the EEG, if something goes wrong, if electrodes fall off, there really isn't an easy way to replace those or fix them. So the rest of the recording will just make do with the electrodes that we have. Finally, the continuous EEG is the one that we get in the hospital. Duration can be anywhere between 30 minutes, if we get the answer that quickly, to several days. Eventually, electrodes need to come off because there's a risk of like skin breakdown when they're attached for a long time. But even then, we can then replace them after, a day or so and continue the study. So this type of EEG is essentially only done in the hospital, either in regular units around the hospital, as well as Dr. Sadat touched on a little bit earlier, epilepsy monitoring units. And I think that's probably where I'll end. Since you've heard a little bit about epilepsy monitoring units, these are these specialized units that we have in hospitals dedicated to studying epilepsy and seizures. So there's many different functions of an epilepsy monitoring unit. It can be, we can bring patients in because they're having events at home and we're not sure if they're seizures or if they're not, and we'll try to capture them on EEG. We can bring patients in when we know they have seizures, but we want to figure out what type. Are they focal seizures? Are they generalized? Where might they start? We'll bring patients in, even if we know all of that information, but they're at home and they're having a lot of side effects with their medications, or they're at home and they're having a lot of seizures despite being on a lot of medications. The epilepsy monitoring unit is a controlled environment where we can make more rapid changes to meds under supervision, so we can help either fix the excess seizures or the side effects. And then finally, an important role of an epilepsy monitoring unit is that it can be used in the workup for a surgical evaluation for epilepsy. And you'll hear a lot more about that from some of our later speakers. And Dr. Sadat already mentioned, one of the reasons I wanted to bring it up is because we are very excited to be opening an epilepsy monitoring unit just down the street in Pleasanton within the next few months. And I have a couple more slides, but I think I'm out of time, so I will speed through the rest of that and just say, we'll take one more. Do we have time for one more question? Right.
Just like whether the slides or recording of this lecture or the lectures today will be available.
We are recording this. That's why everybody has to have the microphone, so that people on Zoom can hear it, and later on they won't hear us just responding to randomness. I don't know if the slides will be made available individually. I personally would be okay with it. I just don't know that answer offhand. So I think we probably can make the slides available, because we recognize that no one in here is going to remember every single thing that is said, and we're hoping that these slides can be good resources for you guys, things that you can look back on later if you have questions. And I think with that, thank you guys all for your time. Thanks for being here today. And I think Dr. Sadat is after me. Thank you.
No, this isn't going to work too well. Let's see. To listen.
everybody. Going forward, what we're gonna do, my name's Tony Zahra, I'm with the Epilepsy Foundation. He's the boss. I'm not the boss. Dr. Christian, Maureen's the boss. But what we're gonna do going forward is we're gonna let the slide presentation finish and then answer questions, and that way we can cover all the slides, and then we'll have questions at the end of each segment. Thank you very much.
It should have just been in the same one. Okay, you're fine.
Okay, hello again, everyone. My full 14-letter name is up there, but I use the part of my last name before the hyphen. So I go by Dr. Sadat, and I'll be talking to you about some of the treatment options that we have for epilepsy today. So we'll discuss the basics of anti-seizure medications. We'll touch very briefly on some dietary treatments for epilepsy, and then we'll have some time for questions and answers. Our goal in the treatment of epilepsy is always to give our patients the best quality of life they can have. It's nice to have 0 seizures and 0 side effects. That is really our goal. But the art of medicine is required to reach the goal for each individual patient. Sometimes it's not possible to have 0 of either one of those. But let's talk about seizure medications as a way to reach that goal. So about 2/3 of patients who have epilepsy will be able to have no seizures with 1 or 2 medications. So that's 60 to 70% of patients. The rest of the patients, remaining 30%, they will require another type of treatment. Their seizures won't be controlled with medication alone. There are some options that we have for those patients. This is just another way to look at this information or think about this information. So in somebody who is newly diagnosed with epilepsy, about 50% of those patients, they'll be seizure-free with just 1 medication. 50% of them will still have seizures even though they're on 1 medication. So of that 50%, about 13% of them will become seizure-free with a second medication, and that leaves about 40% of those patients that will still unfortunately have seizures despite being on 2 seizure medications at a good dose. So once you get past the second seizure drug column, the numbers don't look great. Only 1% of patients will become seizure-free with the 3rd seizure medication, and then 3% with the 4th seizure medication. So that's why once someone is on 2 seizure medications at a therapeutic dose and they're still having seizures, that's the time to think about something else other than medications. And this slide basically shows that. If you're on 2 medications and you're still having seizures, you technically have refractory epilepsy or drug-resistant epilepsy, and it's time to move on to another type of treatment for epilepsy. So let's talk about the medications. There are a lot. We have a lot of seizure medications, but that was not always true. This may be a little bit far to see from the back of the room, but until around 1940, there were less than 5 seizure medications. Phenobarbital, I think, is something that people have heard of. It's sometimes used in children, but that was one of very few options that existed. Starting around 1940 until 1960, we had more medications. I think the most commonly used one in that group is phenytoin. So phenytoin is still used today. It's a 1st-generation medication. It's effective medication. Between 1960 and 1980, some other 2nd-generation medications came out. Depakote, carbamazepine, those are the common ones in that category. And then starting the 1990s to the 2000s, we have a lot of additional medications. These are the 3rd-generation anti-seizure medications. A lot of them have less side effects, and are a little bit more targeted than the earlier ones. Keppra or levetiracetam is the most commonly used seizure medication, and it's in that last category of medications. So all seizure medications share the property of suppressing seizures. So the seizure medications, we used to call them anti-epileptic drugs, and now we call them anti-seizure medications because they really just suppress the seizure. They don't get rid of the problem or cure the problem. They just help suppress the seizures. And they do this through different pharmacologic mechanisms, which we will talk about. I think this one just says exactly what I just went over, so I won't repeat that. The seizure medications do alter the chemical and the electrical activity in our brain cells. And it's important to know what kind of seizures you have, because like Dr. Roberts mentioned, the type of seizure you have also affects the type of medication that will be most effective for you. For focal seizures, most anti-seizure medications are effective, but for generalized seizures, you want to make sure that you're using a broad spectrum anti-seizure medication. Some medications can make certain types of seizures worse, so you want to make sure you know exactly what you're treating to get the best outcome. So this is a picture of a nerve cell, and these two pictures that we're going to look at kind of highlight the main mechanisms used for most anti-seizure medications. So the seizure medications, they either decrease the excitation of the brain cells, and they do that by decreasing glutamate, which in this picture is the yellow circles here in the middle. That's glutamate. And a lot of the seizure medications work in this mechanism of decreasing excitation. Keppra works in this way, topiramate works in this way. They work on different receptors. The second mechanism that we have in the seizure medications is to increase inhibition. And GABA in this picture is the yellow circles. That's the inhibitory chemical that is used by our brain cells to communicate with each other. And some of the medications, they increase GABA and they help to decrease seizures in that way. Okay, so we're not going to go through this chart, but it's here in case you guys ask me questions and I need to look at this chart. So when you are choosing your anti-seizure medication, you want to know what you're treating, like we talked about. Having the right seizure medication, knowing what type of seizures and what type of epilepsy you have will help lead to the right treatment. This picture shows medications that come in different shapes and forms and sizes because our seizure medications can come in different shapes and forms and sizes. So if someone can't take a pill, there are other options. And a reason to have a neurologist that you trust and an epileptologist is because they will get to know you and also tell you about the side effects of each individual medication. They'll go over your whole medical history, and then they'll make sure that you're on the right medication that will work best for you. Okay, so seizure medications can have side effects, and they can have a lot of side effects, but optimizing the seizure medication for seizure freedom is something that you can do with your seizure specialist. This slide is really in here so that you can make sure to tell your seizure doctor, your neurologist, all of the medications you're taking and also all of the supplements that you're taking, because a lot of our seizure medications interact with other medications and supplements can also have interactions. So I thought I would go over a case to kind of make this less boring and highlight one of the questions that we often get as epileptologists. So this is a pretty typical case, a 49-year-old patient with refractory epilepsy who's really tired of seizure medications, and he asks for a prescription for medical marijuana. He's scared of invasive surgery and devices, and how do we counsel these patients? So usually for these patients, say that we don't have data that shows that medical marijuana decreases the frequency of seizures. We do have a medication that is an extract of marijuana, cannabidiol, and I will talk to you guys about that briefly. Actually, let's just talk about it right now. So cannabidiol is a medication that was approved by the FDA. It is an extract of marijuana. It is approved for patients who have Dravet syndrome or Lennox-Gastaut syndrome. And those patients have frequent seizures. They also have a lot of cognitive symptoms. They often have a lot of cognitive symptoms. So the side effects of cannabidiol do not outweigh the benefits for those patients because they already have some side effects, but common side effects of cannabidiol can include somnolence, GI symptoms are very common, fatigue. And so there are typically medications or alternatives that have less side effects for patients, and that's usually what I discuss with patients. It's also pretty pricey, so it's something that can be used for the right patient at the right time, but requires a educated conversation.
Is that a comma?
Is that a comma?
Yeah. Price tag?
Yes, yeah, yeah. $32,000. Yeah, and I think the slide is 3 years old, so it's probably a little bit more expensive than that. Yeah. Okay, so another case, 51-year-old female with episodes of deja vu that are well controlled on Keppra or levetiracetam, but she has dark intrusive thoughts and she says that she's tried everything and she wants to know if there are other options. She's already tried lamotrigine, Vimpat, oxcarbazepine, clonazepam, zonisamide. So she wants to know if there's anything else that she could potentially use. So I will focus, there are other things that can be done for this patient, and I will focus on the first 2 items on the list for today. We have data there is good data in children that shows that vitamin B6 supplementation can help with the mood side effects of Keppra. There is data in adults, and there are ongoing studies that are very promising, showing that up to 100 milligrams of vitamin B6 can help and is safe for use in adults. Vitamin B6 is a vitamin, so a lot of people are willing to try that to see if they can tolerate their seizure medication. Briviact or brivaracetam is like a sister or a cousin of Keppra. It's newer, it binds stronger to the sodium receptor. Okay, I'll take questions later. I thought maybe somebody had a question, but then changed their mind. Okay. And some people do have decreased mood side effects on brivaracetam. Not everybody, but it is something to consider. Okay, so I'm going to touch briefly on the ketogenic diet with the caveat that I do not have special expertise in the ketogenic diet. We do have a neurologist at Stanford in Palo Alto who has a ketogenic diet clinic, and we have dietitians who can talk to patients about this. Today, I'm just going to talk about the basics of the ketogenic diet. So the typical American diet is very carbohydrate heavy. That's the gray area on the left there. We usually have mostly carbohydrates, some protein, and some fat. The ketogenic diet, as you can see, is pretty starkly different from that. It is, we hear keto or I've gone keto or ketogenic pretty often. We see it in the grocery store, we see it in the bookstores, but the ketogenic diet for epilepsy is pretty strict and it's very hard to do. So it's not very fun. It's used mostly in children, and about 90% of children who go on the ketogenic diet, they have to be hospitalized to allow for them to actually follow the full ketogenic diet. They have to fast for about a day before they go to the hospital. The second day when they're in the hospital, they get half of their calorie needs. And then the third day they start getting foods like steak or butter and things like that. So it's a challenging diet. And it can have side effects like constipation, gastric reflux, high cholesterol, vitamin deficiency. These are treatable, and with a trained physician, you can monitor for these side effects and treat them. Because it is such a stark deviation from somebody's normal life, it does affect quality of life significantly. And so we try to use it only for people who we know it's actually going to help. And these are the reasons that we mostly use the ketogenic diet. Most of these indications are for pediatric epilepsy syndromes like Angelman syndrome or mitochondrial diseases. Lennox-Gastaut syndrome is something that can continue into adulthood. And a lot of times in the hospital, if someone is hospitalized for status, we can consider the ketogenic diet if their seizures are very hard to control. Okay, so a lot of people who consider the ketogenic diet actually end up being put on a modified Atkins diet, which is still very different from the standard diet, but is a little bit less restrictive than the ketogenic diet and is still quite effective. It allows for a little bit more protein and a little bit more carbohydrate, 6% instead of 2%. So this is my last slide about ketogenic diet in adults. The black area there is about 30 to 40% of adults who try the ketogenic diet stop it because it's either too hard, too restrictive, or not effective for them. About 20%, 10 to 20% of patients can have seizure freedom with the ketogenic diet. It just means that it has to be the right person and the right disease to get the ketogenic diet. So I went pretty quickly through medications. There are other options, neurostimulation and surgery, and my colleagues are going to talk to you guys about that. I wanted to leave some time at the end for questions.
Is it ever recommended to test for therapy? Oh, sorry. Is it ever recommended to test for therapeutic levels on a regular basis?
Yes, yeah. So usually at an epilepsy center, they will check your therapeutic level when they start you on the medication, when you get to the goal dose, and then intermittently. It kind of varies based on the medication that you're taking.
Is it something that we should be suggesting to the physician to order for labs?
That's definitely a good question. Yeah, you can ask your physician.
Okay, thank you.
Thanks.
How do you know when to count out one of the like anti-seizure medications that you've tried when you're kind of moving through that first, second, and third medication you're trying?
How do you know when you're not responding to
Yeah.
that medication? That's your question. So it should be a conversation between you and your doctor, but there's usually a recommended therapeutic dose for each seizure medication. So I'll use Keppra since it's the most commonly used medication. You want to be on at least 500 milligrams twice a day of Keppra. You probably want to try a higher dose than the initial starting dose. The basic answer is whenever you are still having seizures at a therapeutic dose of the medication.
Just wanted to know how quickly can you diagnose exactly where the seizure is starting in the brain? And then isn't that the most important thing to find out very quickly so you can treat very specifically with medication? Like, there's the inpatient diagnosis, and how many people do have that procedure to find exactly where the seizure is starting?
That's a very good question. So there are different ways to understand what part of your brain the seizures are coming from. I think one of the benefits of seeing a neurologist or somebody who subspecializes in epilepsy is that they've seen hundreds of people who have different types of seizures. So you can just tell them your clinical symptoms a lot of the times, and we can say, oh, based on the symptoms that you're having, this is coming from the parietal lobe on the left side of your brain, because that's where these functions of your body are concentrated. There are a lot of symptoms that come from different parts of the brain, and for those patients, we get a routine EEG. About 60% of the time, the routine EEG will give us some clue as to where the seizures are coming from. MRI is also helpful. About 40% of the time you get those diagnostic tests and they don't give you an exact answer, and those are the patients that go on to get the longer EEGs or get admitted to the epilepsy monitoring unit.
There
Yes.
was a question on Zoom.
Sure.
Can I give that to you?
Sure. Okay, so can physical exercise help with seizures? Yes, absolutely. So the American Academy of Neurology recommends that patients have 4 days out of 7 days a week of physical exercise, which is defined as something that increases your heart rate above your baseline for 30 minutes. And that does help with decreasing the frequency of seizures. We always want you to be safe. So I think if you're having seizures that are making it unsafe for you to be on a treadmill, for example, you want to focus on getting your seizures controlled and then go on a treadmill. But when you can, it helps decrease seizure frequency and also helps with cognitive symptoms.
Hi. Your slide that talked about the first, second, and third generation, I was of the understanding, and I probably made it up somewhere, that there were 3 different families of medications and that they each worked in a different kind of space. Like you had a couple slides where it had that little teardrop guy and
Yeah.
what is that of?
Yeah, so
Are there 3 families that work in different manners, or is it just 3 generations over time?
I think you are talking about the mechanism of action of the medication. So the slide with the timeline is mostly just based on time, the years that the drugs were created. The slide with the teardrop is the brain cells, and then it had all the different receptors on the cells, and I know it was small on the screen, but there are different cell receptors on the cells that the medications work on. A lot of our anti-seizure medications work on the sodium receptors of the cell. They're sodium channel blockers. So that's one main class of seizure medications. Some of them work on the calcium channels. Some of them work on the GABA receptor or the benzodiazepine receptor. Those are the main ones, but there are more than 3 mechanisms of action. Sure. Yeah. Okay, I think we have.
So I may have missed it earlier, but I saw on one of your slides that it mentioned enzyme-inducing medications. Can you just describe what that is really quick?
Yeah, so enzyme-inducing medications are medicines that work on your liver enzymes, and they make the liver enzymes that break down your medicines work faster. So the medicine that you take gets broken down faster. It doesn't reach as high of a level in your blood. It just basically goes out of your body faster. It's a good question. We have one more question.
Can you talk a little bit about how you balance side effects such as weight gain with Keppra versus uncontrolled seizures and seizure freedom?
Absolutely, yeah. So you have to kind of customize treatment for each individual patient. I think a lot of our patients do not have weight gain with Keppra, but it can be a side effect. And if for that patient, Keppra is causing them to gain weight, and that's significantly decreasing their quality of life, then we can try to safely transition them to another medication or try to maybe have them on a little bit lower dose of Keppra, but add a second medication to help prevent seizures. other lifestyle things like exercise and healthy eating can also help. Okay. Okay. Do we have time, Maureen, for another question?
Are there any concerns for like the long-term safety of the newer generation of the anti-seizure medications?
Long-term safe, like you mean toxicity from seizure medications?
Just like the safety of using them for a long period of time since they're relatively newer.
Oh, the newer generation medications. Yeah, so we monitor for toxicity. For seizure medications, it is safer not to have seizures. It's better for your body to not have seizures than to have seizures. So we kind of, accept that fact, and then we monitor for the side effects of seizure medications. A lot of the newer generation medications have less side effects. They affect the liver less, they affect your blood count less. But we do look for things like your bone density and your vitamin D levels. Okay, thank you very much.
Yep. Okay, there we go. Good morning, everybody. Thanks to Dr. Roberts and Dr. Sadat for those wonderful talks, and thanks for letting me be here today. Just before I get started, to help me kind of understand who's in the room, I know there's people on Zoom that I'm not directly interfacing with, but the people here, how many of you are either patients or a family member of a patient that has epilepsy? Oh, that's terrific. Okay. And how many of you have had sort of direct experience with epilepsy surgery as a part of this process? Okay. And as my kind of final question before I get started, how many of you would have an uncomfortable problem with a couple of surgical images, like pictures? Is everybody okay with that? Okay. I don't have many on purpose, but I do have a couple just to highlight a few important things, perhaps that could be helpful to kind of gauge that context. So what I'm going to talk about, and I'm sort of treating this as kind of a two-part series here, because what I'll talk about will be predominantly the kind of potentially curative procedures that we have for epilepsy surgery. But as you know, our surgical domain goes into all of the neurostimulation and neuromodulation therapies, which we do a lot of. But Dr. Fisher is going to be giving you that talk, and there's nobody better to give that talk because he actually invented basically that therapy. So it's a true honor, I will tell you, to be able to, for myself, to be able to work with him, but also, for his wisdom and impact on our field. So we're going to talk about precision approaches, and I mean this in a way that on purpose to be capitalized. Our historical perspective about epilepsy surgery has been that it's this big undertaking. Even the surgical procedures I'm talking about primarily, which are the resective procedures where you're trying to get rid of the focus in the brain that's causing the epilepsy. And historically, they've been viewed or thought of as these kinds of big procedures that has a tremendous amount of risk. And that used to be the case. That was true. But we've been able to hone in on our craft over the past 50 plus years to really make this about you. And by understanding what's happening in your brain and or your family member's brain. We don't need to make these enormously dangerous, and we can still make them extremely precise and extremely effective. And so that's kind of the gestalt I want to give you, at least from the start, is that even though we're talking about surgery that certainly sounds scary, and that's absolutely normal for it to sound scary. In fact, it would be abnormal if you were not scared of this concept. But what I can tell you is that, especially at centers that do this a lot, we have a way to kind of make this not scary. And I think it can be something that offers a tremendous amount of hope for the appropriate patients. So that's the reason that I highlight that word. A little bit of background, you already know and kind of heard some of this, but there's about 1% or so of patients that have epilepsy. It's a larger population worldwide. So in the United States, we have relatively limited population percentage-wise compared to the rest of the world. But there are, probably about 70% of patients that can actually be treated well if they are treated appropriately. So that's an important statistic, because this is not something that does not have a hope for treatment. There's actually a lot of hope for treatment, and it includes the medications, obviously, that we talked about, but it can also then include surgery. And so the diagnostic workup really, epilepsy, I think in the pure definition, although Dr. Roberts gave some nice kind of caveats to this, but epilepsy is really 2 or more unprovoked seizures, and really that are more than 24 hours apart. And really you have a series of things that we would do to kind of look into this after you have this possibility of epilepsy. And the main thing we want to do is we want to use tests to rule out or differentiate the epilepsy from being what we call lesional versus non-lesional. So what that means is lesional is that there is something that is in the brain itself that we can see on an MRI or a CAT scan or both, and really is a primary culprit, though is not always actually the cause of the seizure. So we have to do our due diligence there. But that would be one sort of pathway of treatment considerations, and then the non-lesional pathway, which is where we don't see anything on the brain, and that's actually the most common. So the initial management, you heard about this, focal versus generalized is sort of a consideration that we do based on what the seizures look like. You heard about Dr. Fisher's witness protection program after he changed everything. And I will mention that at least when you say it, it's easy to say FIAS versus FOS, but when you read it, it's a little bit confusing. I'm actually not going to lie. He chose only a single letter to distinguish these 2 categories. So FIAS versus FAS, but these are replacing the complex partial versus simple partial terminology. And for I joke, very, very good reason, as he mentioned. And then you do begin your anti-seizure medications, and you heard about the kind of declining of efficacy as you go from one to the next to the next. And so ultimately, for me, the primary time frame of interest is when you are in this category of being, 30 or so to 40% of patients that are refractory to the medication trials. And that's when you might come and see someone like myself. So how do we start this process? Well, I want to first make the comparison that as a part of your workup before you come and see me, we have what's called phase 1 monitoring and then phase 2 monitoring. So phase 1 monitoring is where you get things that are non-invasive. So this will include scalp EEG with the video, like you talked about. It's actually wonderful that you have an EMU coming here. That's terrific. I congratulate the team here. That's going to be wonderful. But this is where you can get that type of workup, is the phase 1 workup before you have anything that might be invasive. So you can do scalp EEG. You can do what's called a magnetoencephalogram, MEG. That's the difference between EEG and MEG is just the way that the brain activity is being measured. So EEG is an electrical activity-based measurement. MEG is actually using basically the idea of magnetic poles that are formed from electricity inside the brain. So electricity is still kind of the core language of the brain, but you can measure it in different ways. So you can measure it with looking at the magnetic poles that are formed. Then you can look at positron emission topography, so PET scanning. So that's a way to look at the metabolism of the brain and how much glucose is being used up by different parts of the brain and other, not just glucose, other also metabolic markers. And that's similar concept with this idea of SPECT. Now, the main difference between these two in concept is that PET is what we do interictally, meaning between seizure events. Ictal means seizure, interictal is between seizures. And so you can get this done easily as an outpatient, as a part of your workup. And we do that for everybody. The SPECT is really something that we try to get during a seizure. So it's called ictal SPECT. And that is obviously more challenging, but there are some patients in whom we do that. And particularly patients that have seizures very frequently. Now, I treat kids as well as adults surgically. So we tend to have more success with our pediatric patients trying to use an ictal kind of imaging modality when they're actually having their seizures, because they tend to have them more frequently. And then there's also functional MRIs. So in addition to the MRI and the CAT scan, the kind of structural ones, you can get an MRI that also we ask you to do silly things like name some, things you see on a card, or do some things with your hands, or open and close your fist, etc. So while you're doing those things, we actually see how the blood oxygenation in the brain is changing, and areas of the brain that are active will take up more oxygen at that time. And so we can kind of get a map of where these functions grossly live inside the brain tissue. And the PET scanning that I talked about, the main important point with PET scanning is that actually, even though the part of your brain that is most active theoretically is the part of the brain that causes seizures, while you're having a seizure, it's extremely active. When you're not having a seizure, so interictally, between seizure events, it is actually less active. And so on the PET scan, you actually see that the area that is of concern has lower metabolic activity than the rest of the brain. And so we use all of these pieces of information to try to give us an understanding of what's going on in your brain. I think to your point before, which is, how do you try to find out what's going on in the brain right away? So these are all the modalities that we would use immediately, or in short term after you have your diagnosis and you start getting into the refractory period, not responding to medications extremely well, etc. But there's still 30 to 40% of patients, despite doing all this, despite trying all the medications, who will not have a good response to the medications. And this is when we can start thinking about doing more. And this is one of the images that I was referring to as a surgical picture. This is actually a picture from when we first started using a specialized robot called the ROSA robot to do these procedures. And you can see that the head is shaved. We did used to do that when we first started. I don't do that anymore at all. So you don't have to have a full head shave. But you can see kind of the idea behind this is that we have tiny little nicks in the scalp. They're about the size of a paper cut, each one of these. And within those, there's a small opening in the bone that we create. And then we put this tiny little wire. This wire is 0.86 millimeters in diameter, less than 1 millimeter in diameter, in different parts of the brain tissue. It's extremely soft. It's like a spaghetti noodle, actually. So it's, in the way that we do it, it's also extremely safe and does not damage brain tissue the grand majority of the time. There are obviously some risks associated with it, which we'll go over in a second. But all in all, it's an extremely effective procedure and a safe procedure. And the whole point is that what we are doing is we're trying to recapitulate what happens with the scalp EEG. But the problem with the scalp EEG is that for the signal from inside the brain, wherever it's coming from, once it gets to the scalp to be measured by this device, it's already by definition spread. So you can't get to the scalp unless it's already spread to the scalp, the signal itself. So that in a lot of cases is enough, though, because you can combine that information with other things as well as with the semiology, which is the word for what the seizures actually look like. And you can combine that information sometimes to give you a good sense of where things are coming from in the brain. But many times it's not enough because of that very fact that by the time the signal gets to the scalp, it's already spread. And it can be a little bit confusing to know exactly what is happening inside the brain tissue itself. So the idea behind this procedure, which is now considered a phase 2 monitoring, is to try to get directly to the source of the problem and measure the brain activity coming from inside the brain tissue itself, so you can get a very clear picture. Yeah, Dr. Fisher.
Could you say roughly how often that's necessary?
Yeah.
How often you have to put wires in the brain if you're going to do surgery?
Yes, that's a good question. So Dr. Fisher's question is, how often are we trying to put wires into the brain to do this type of monitoring? I will say, and I'm actually going to go to the next slide to help with elucidate this a little bit. When we first started doing this type of monitoring, we actually did it in a way, and again, this is there's only one more picture after this of concern, but this is a picture of what we used to do this type of monitoring, which was actually exposing a pretty large part of the brain tissue and laying these sheets of electrodes on top of the brain directly to kind of get at that same concept of getting signals directly from the brain tissue itself. Now, when we did this approach, this has a lot more kind of discomfort and other things associated with it, risks as well. So when we were doing it this way, I think it was much less common. And we would certainly do it, but we would reserve it for patients that really we could not make an educated guess. And that ended up being a lot of patients. We would make an educated guess, probably about 40% to a half of the patients that we would see. We would make an educated guess and go straight to a surgery to deal with that educated guess. Now, because we do it this way, where we just have what we call percutaneous approach, just through the little nicks in the skin, it's much better tolerated. And so, patients can recover from that, and we can have a much quicker recovery. It's a much more benign procedure. And so because of that, the numbers of when we actually use this approach have skyrocketed. And, I would say that in the past, when we would have a surgical conference and maybe 40% or up to 50% would get sort of the strips and grids type of a procedure. Now we're more in like the 80% range of patients that we're discussing, that we are favoring doing this exploratory phase 2 mapping. And the reason is that it just is much better tolerated. That's the number one reason. But the number two reason is that the information that we get from it is actually critically important, because in the past, when we had electrodes just on the surface of the brain, we would get some type of information from that. But as it turns out, a lot of epilepsy comes from deeper within the brain tissue. And again, if you're on the surface of the brain, it's kind of like being on the scalp. I mean, it's a little bit better, of course, but the concept is still there, that by the time the electrical signal gets to the surface of the brain, if it's coming from deeper, it has already spread by definition. So what you're seeing is actually a spread pattern, even if you're laying sheets on top of the brain. So what we've done with this procedure, by creating this robotic, what we call stereotactic EEG or stereo EEG or SEEG, what we've done is we've created a way to actually sample in an even less invasive manner from deep inside the brain, as well as on the surface. So it gets us both. And by doing that, we now have a much better understanding even of epilepsy and what happens during seizures and how they spread through the brain tissue. So that, I think, combined with the less pain, faster recovery, less risk of infection, better wound healing, combined with the fact that we are now sampling from areas of the brain that were not as easy to sample from before, and it turns out that a lot of those regions of the brain that are deep are actually where seizures are starting from, has made it so that we are now much more inclined to do this procedure than not. So that has become certainly our practice. And I will tell you, there are centers that still do this sort of strips and grids approach. And I think and I'll show you at the end a case when sometimes that can still be useful. It can still be the right thing to do. And in particular, if you think there is an epilepsy coming from the surface of the brain, and you have a reason or several reasons to believe that, then it can be helpful to use that type of an approach. But for the grand majority of patients, it's probably not coming from the surface of the brain. And so, to use this strips and grids approach as your default, I think is really a shame, and certainly not what we do at Stanford. And we are by far, I would say, over 95% of our phase 2s, our stereo EEG approach. So what happens once we gather that information? Well, the entire hope is that we can use the information from the phase 2, from the stereo EEG, to give you actually not just a chance, but a really good chance at cure. That's our goal. Our goal going in is cure. Can we create an approach that will cure your epilepsy? Now, the best way to cure your epilepsy is to find a part of the brain that is generating the seizures, and then to remove that part of the brain tissue. There's a lot of nuances to that. And the main one that would be on first and foremost on everybody's mind is, can you do that safely? And I will tell you that the grand majority of the time we can do it safely. And if there's a reason that I don't think we can do it safely, we won't offer it. Or we would talk about it, but say we would not recommend this, So when we're talking about the potential for removal of an epileptic source inside the brain tissue, and we're talking seriously about removing that, it is already with the knowledge that we have discussed it as a group, and we've come to the conclusion that it would be safe to try to do this. Now, you don't have to do it. This is not a requirement in terms of the strategy of treatment. But this is the one that by far offers chance at cure. And so the landmark trial, this was in the early 2000s, showed basically if you do a full temporal lobectomy, this is the temporal lobe you saw from Dr. Roberts' slides before. This is the temporal lobe, and you do a temporal lobectomy, which is essentially the front half of the temporal lobe. If you remove this front half of the temporal lobe and the hippocampus, which is the kind of darker green that's deeper in the temporal lobe, then at that time, there was a 58% chance of seizure freedom in a randomized control trial for the group that got surgery, and only an 8% chance or 8% of patients in the non-surgical group went on to seizure freedom. And there was a 2% chance of permanent, or 2% rate of permanent adverse effects. So certainly not zero, but that's not a terrible risk profile there. And so that was early on. That was when we were doing this before kind of having all of our really tailored approaches that we have nowadays. A lot of those procedures were done without a phase 2 because it was an educated guess based on the scalp EEG, based on the semiology. And so now, because of our tailored approaches, we're even more precise and personalized. I can actually use something called electrocorticography, which is a way to read the brain tissue's electrical patterns during the surgery itself. Under anesthesia, during the surgery, I can use these techniques to actually measure the brain activity to better understand where in the temporal lobe is actually the problem. And many times this gives us a very clear distinction that this area is the problem, and as soon as you get back here, there's no more problem. And so we can use that to tailor the resection. We only get rid of the tissue that's actually causing the problem. So there's lots of reasons for improving even from that early trial. And now we're probably closer to about 70% as a seizure freedom rate. Seizure freedom, that's cure. I'm talking about total cure. So that's pretty good. And, with our approaches of tailoring it, we've also had the kind of ability to understand that some patients that have temporal lobe epilepsy it's really only coming from the hippocampus and the amygdala. And in those scenarios, we have a surgical approach where I can actually come from underneath the temporal lobe and just remove this very deep part of it, which is where the hippocampus is. And by coming underneath the temporal lobe and removing just the deep part, we can actually preserve the function of all of the stuff on the outside. So that's a pretty big difference in kind of a tailored approach. And that also provides an extremely high rate of seizure freedom. Again, once we have learned and understand your epilepsy, we can tailor it to what's going on. Now, we also have newer ways of doing that type of a thing, which we do a lot of at Stanford as well. It's something called laser interstitial thermal therapy, or LIT, or laser ablation. So this procedure is a procedure where I make an incision that's less than 5 millimeters. Again, it's basically the size of a paper cut almost, and we stick a laser fiber into the part of the brain that's causing the epilepsy. Now, this approach is something that we as a group prefer when we have a very small area that we have identified as being the problem. It can also include that hippocampus and amygdala, if that's the area that we've identified. So this laser approach is an approach that we use most commonly if it's just coming from the amygdala and hippocampus. Then we can use a laser fiber to go into that part of the brain. And we use laser energy to heat up and destroy the epileptic brain tissue. And this is all done with real-time MRI. So I'm doing this in the MRI scanner, actually. You're asleep, but I'm seeing everything in real time in the MRI. And that's for both the insertion of the laser as well as the tissue heating. And that's something called MR thermography, where it can measure the temperature at every voxel of the brain that it's seeing. And instead of giving you a structural image, it's giving you a temperature. And by seeing that temperature, I can see what is heating up and then what I need to protect from being heated up. And so we can fashion this approach to try to deliver the energy right to the source of the problem and protect the nearby structures that need to be protected and are not the problem. And importantly, you can actually also sample tissue at the same time. So if that's a question that comes up, can you actually get a biopsy, at the same time if there's a concern that maybe we want to, maybe there's some benign tumor or something there that's causing this, then we can sample at the same time. The effectiveness of that sample is not as good as if you have it with an open surgical approach, the one that I talked about here. If you do it like this, you have much better sampling of the tissue and a much better likelihood of diagnosis. So this is where the nuance will come in based on what is happening in your case. But for the grand majority of patients, especially adult patients, I do the resective approaches probably much more in kids than in adults. But typically there's usually a scar tissue that has formed, and that scar tissue is what's causing epilepsy, and we don't necessarily think it's a tumor that needs to be biopsied. So the majority of the time, we are actually not worried about getting the tissue sampled properly, which is why laser can be really a good option in those scenarios. The seizure freedom rate is a little bit less than the open surgery, but it's a tiny little laser fiber that's about 1 millimeter thick. So there's trade-offs there. And we, this is all the discussion that we have together about that. This is a kind of a view of what that looks like. This is the intraoperative MRI platform that we use to guide the laser fiber into the hippocampus, for instance. And so there's a whole series of steps that we use to align it all, guide the laser fiber, and then do the ablation. And the last kind of category of these really potentially curative procedures is something called the disconnective procedure. So this is a procedure where we have a much larger area of the brain that is causing a problem. And sometimes it can actually be the entire hemisphere, again, this is far more common in kids, where you have the entire left or right hemisphere that's causing seizures. And the problem for them is that the side of the brain that's causing the seizures is actually inhibiting the normal part of the brain from functioning. So they have a lot of developmental problems, lots of difficulties, both cognitively, motor, milestones, etc. And so for these kids, we know that if we can just stop the two hemispheres from talking to each other, then we can actually give them a chance at a relatively normal life. I'm not joking about that. So there's actually recently, I just got a video from a parent last week on a kid that we did this on probably about, I don't know, 10 weeks ago or so, 10, maybe 12 weeks ago. And at the time that we did this procedure, it's called a hemispherotomy, where we disconnect the two hemispheres from each other. I got, the patient was actually basically bedbound, unable to communicate, unable to move, was having a lot of difficulty, couldn't eat. So it was really spiraling. And we did this procedure, and she just sent me a video. He's walking. He's like walking in his therapy class. Yeah, it's amazing. So it can really be a tremendous impact when you do it with the right patient. And the way that we do that is actually not what you think about when we think about removing half the brain, which is how we used to do this. So that was called a hemispherectomy, meaning a removal of half of the brain. What we do now is we just do a hemispherotomy, which is a disconnection between the two sides of the brain. So it's a much less invasive version of doing that. And then the kind of baby version of that is something called the corpus callosotomy. So the corpus callosum is the main highway between the two hemispheres. It's not the only route of communication between the two hemispheres. So hemispherotomy, you do a disconnection of the corpus callosum, but you also do other disconnections. But you can also just do a disconnection of the corpus callosum, which is, again, like I said, the major highway of the brain. It's this kind of white structure here. And we can do that either with an open surgery, again, a pretty minimally open surgery. The craniotomy is only about 5 centimeters large. Or you can do it with a series of lasers, and we can send 2 or 3 lasers in and try to do the disconnection with laser heat. So this is especially good for what Dr. Roberts talked about at the beginning, something called drop attacks or atonic seizures. And again, in kids, we do it a lot more frequently because they just tend to recover pretty well from this procedure. Adults, it's a little bit harder to recover because your brain has been used to talking to itself for a long time. And so when you get rid of that major highway, it does cause more challenges to overcome, but they can be overcome. And it just depends, again, on how bad are the drop attacks. And if the drop attacks are causing the potential for a fatal accident on a daily basis, then that might be something that we would take as a risk. So again, this is all tailored, it's all personalized. We have other solutions Dr. Fisher will talk about that might be helpful for these drop attacks, though the evidence is still suggesting that corpus callosotomy is our most definitive approach to that. But we are developing new therapies as we go here. So that's kind of the primary set of potentially curative epilepsy surgeries. And, it's been highly successful. These are all sorts of major publications, major impact that epilepsy surgery has had on patients. And I always tell patients, that again, it would be, like I mentioned before, I know it's scary, and it should be scary, because if you weren't scared, I think it would be a little bit weird. But yeah, Dr. Fisher. Yeah, thank you. We're almost done. So it should be scary, but it should actually also offer a time of hope. There's a lot of hope with epilepsy surgery. It's been proved to be extremely successful in many ways. And even for the most complex of epilepsies now, we have treatment strategies that Dr. Fisher will go over that are also extremely good. And they don't have quite the same chance at cure, but they can have a significant impact in decreasing the impact or the problems that arise because of the epilepsy in your daily life. And so in the last 2 minutes here, there's things that we're doing at Stanford to continue on this approach of innovation in the field. And one of them is trying to combine the use of surface electrodes, a grid, a sheet on top of the surface, as well as depth electrodes beneath it. And by doing this in a patient in whom had a lesion in the superficial part, the surface of the left temporal lobe. It was right near the area where he produces language, actually speech. And so we were able to map everything with this approach, where the speech was coming from, as well as where the seizures were coming from. And it happened to be coming from underneath. This is my final picture here, the most gruesome of them all. But the point here is that we were able to map that the problem area was here. This number 7 and this number 6 is where we had him awake in the operating room. We identified these areas as being potentially regions that created speech during the 1 week where he was inpatient with these electrodes. And we identified that one of these electrodes at the depth was where the problem was coming from in terms of seizures, which is below the lesion. So we kept him awake and we mapped all this in the operating room, and we mapped that this area here, when I deliver a little bit of electrical pulse, stops his speech as he's talking. So that's a dangerous area. Same thing right here, little bit of electrical pulse stops his speech. So that's a dangerous area. But on top of where the lesion was, which is common, this part of the brain is not normal, and it does not have function. It did not, at least it did not have gross function. And so we were able to work in between these little blood vessels here, keeping these two parts of the brain safe. And we got to the electrode that I still had in the brain at the time of the surgery, where the seizures were coming from. So we can use these kinds of really advanced approaches to try and provide both a safe, even in the most dangerous of areas, a safe and effective way to treat and potentially cure epilepsy. And then we're also now doing something that Dr. Fisher will talk more about, which is sampling from the switchboard of the brain. So the thalamus, the deep structure inside the brain, we've pioneered an approach to actually be able to sample from that part of the brain when we do this phase 2 monitoring. The importance of this, the thalamus, this kind of middle part of the brain, is not a part of the brain that actually causes seizures, but it is the primary part of the brain where seizures will then spread through. And depending on how it comes through the thalamus, we have some hypotheses that by identifying that, we'll understand what your seizures are actually doing. We might be able to drive some personalized approaches to stop that sort of massive spread of seizures by intervening in the switchboard. And now this is something that we would do when we don't have a good way of offering a potential curative approach, which was the ones that I mentioned before. And of course, we are, as we all know, using machine learning approaches to do everything we possibly can, including now using this type of information to personalize the therapies for you. We're also doing stem cell approaches now as well. We've just started that at Stanford and other centers. And so the entire purpose is to create these personalized approaches and tailored approaches based on what's happening inside of your brain. And my last slide here is actually just a plug for one of the most emerging technologies, which is focused ultrasound, which is where we have a helmet that's on top of the brain that, without any incisions, delivers all these ultrasound beams individually. They don't do anything to hurt the brain, but where they collide, they can cause the brain to heat up. And it can be a sort of an emerging option for ablating a small focus inside the brain. And this is actually a picture that I painted in Microsoft Paint, and it got on the cover of Epilepsy, so it's a hot topic. I think with that, I'll give it over to Dr. Fisher.
Excuse me, Dr. Buch? Yeah, yes, there is a question. So,
sure.
May I ask a question that
Yeah.
came through the Zoom? So the question is SPECT used outside of pre-surgical diagnostics specific to epilepsy patients? And that was a Zoom question.
Yeah, so SPECT, is it used outside of pre-surgical diagnosis, meaning?
Just part of the surgical workup.
Yeah, so I think the answer is that it is used as a part of the surgical workup. So if there's a part of the brain that lights up with ictal SPECT, then it's a high likelihood that that's a problematic zone in the brain.
I noticed when you had some of the facts about how surgery has become more successful. But one thing I just didn't see is what percentage of the success rate of people not having seizures after surgeries are able to get off medication too?
Yeah, that's a terrific question. So in our primary data around the success rate of surgery, whether or not you have you are on or off medications at the end is not a part of the classification. So the classification of response to surgery is basically what happens to your seizures. And we grade that response typically when patients are still on their medications post-op. So the weaning of medications is an extremely important part about this whole process, but it doesn't actually represent, it's not captured as well in our outcome data, but it is something that we hope to be able to do for every patient if they are in that 70% that might have a seizure freedom response, but it doesn't always happen. More questions?
Hey, can you still perform these like the R, EEG and all late with cranioplasty?
Yeah, that's a good question. Yeah, I mean, let's put it this way: it may not be on label, but there's a lot of what we do that is is not a part of the normal routine, and so we're very used to doing things that are not a part of the normal routine. So if I'd have to look into all the details, but I think it would be feasible. Yeah. One more question.
I'm somewhat curious. So when you separate the hemispheres versus taking a hemisphere out, is that tissue still alive, or is it just the communication is severed? Or
yeah, that's a great question. Yeah, the tissue mostly is still alive if you keep it in the brain, but because the communication is severed, that whole hemisphere is not actually functional typically. It's seizing all the time from all different areas. So you can keep it in the brain and let it keep doing that to itself, but it really makes no impact on the function of the patient. So, and obviously, in fact, it actually hurts, the function of the patient. So, okay, awesome. On to step 2 with Dr. Fisher.
Well, it came off the clip. I'll just hold it. You've heard a lot of information. What have you heard? You've heard that about 1% of the world has epilepsy, and that things go swimmingly well for about 2/3 of those. On a medicine, not much in the way of side effects. They do fine on it. Seizures are under good control. So that has misled a lot of people, even doctors, to think that epilepsy is pretty much a solved problem. If you do the calculation, 1/3 of 1% is a number larger than all brain tumors. It's a number larger than all multiple sclerosis, all muscular dystrophy, all Lou Gehrig disease. So it is far from a solved problem. And I'm grateful that companies keep trying to invent new seizure medicines. You heard from Dr. Sadat, we have, I think, 27 of them licensed in the United States. You know that if there was one that worked great, we would only have one and not 27. But the newer ones are better in many ways than the older ones. And I encourage you in the break that follows my talk, go to these tables because they're representing, I think, the 3 newest seizure medicines that we have available, and get some information on them. Now, if you are in that 1/3 where the seizures aren't controlled, then I expect a lot of people in this room either are or have family members who are, because if your seizures were controlled, you probably wouldn't care so much to come here and hear what's new. Then there's maybe the surgery to think about that you just heard about from Dr. Buch. And, the key to the most common kind of surgery, which would be usually on the temporal lobe, be it open surgery or the newer laser surgery that's a lot easier on the patient, is to be able to pin down that the seizures come from one place in the brain, not multiple places, and that place is safe to remove. So I've gone to epilepsy weekly conferences now for over 30 years. And until about the last 5 years, it was often the case that we would hear that somebody's in the third where the medications don't work and they have a surgical workup, and either we can't find where the seizures are starting, what we call the seizure focus, or it's in more than one place. And I would have to tell them, can't help you really. Things have changed. And they've changed in large part because of neurostimulation, which we also call neuromodulation, which has made it really rare for us to say there's nothing we can do. So I'm going to talk about neuromodulation today, but I want to put it in context that you can get your epilepsy cured with an operation. Not always, but cured or almost cured. What would you say, Dr. Buch? About 2/3 of the time in most cases, and helped in a lot of the 1/3 who aren't cured. Probably not off medicines, but maybe medications reduced. The neuromodulation is not a cure for epilepsy, but it very often helps. And I'll talk with you a bit about how much it helps. Am I calling for the slide changes or doing them? On the clicker? These are disclosures. The most important thing to say is I don't actually take any money from neurostimulation companies. I do research for them, but then Stanford gets the money. So what if this is you? You've tried 6 seizure medicines, 4 didn't work, and 2 had bad side effects. Your seizures come from both temporal lobes. So your doctor says, we can't take out both temporal lobes or your memory is going to be shot to hell for life. So the doctors say you're not a candidate for surgery. What next? As I said, there used to be no answer to that, but now there's a whole field of answers called neuromodulation. 3 flavors of neuromodulation are approved in the United States. 2 of them are approved around the world. The first 2 on the left, vagus and responsive. I'm sorry, the left and the right, vagus and DBS, and the responsive is approved only in the United States so far. And let me tell you what these are, and you can be thinking about whether you might be interested in learning more about them. And then I'll also mention at the end a few researchy things that are not approved yet, but I think will be coming to an epilepsy center near you in the near future. So perhaps the first that the public became aware of neurostimulation was from a neurosurgeon named Jose Delgado at Yale, who was a hell of a showman as well as a neurosurgeon. He wanted to demonstrate how he could control a bull's brain by radio waves to an implanted stimulator in the bull's brain. So he put electrodes of the kind that you just saw by Dr. Buch in the motor control center of a bull and had a radio transmitter that would turn that stimulator on and off. He then went into a bull ring with some New York Times reporters around and waited until the bull started to charge him and then pushed the button on the stimulator. Personally, I think it would have been like a great ad for Duracell batteries. You don't want to fail at the wrong moment. And the bull would go into this twisting spiral involuntarily and then look very confused. So that's the first that I heard about neurostimulation. I was, I think, not even a medical student at that time. And it's been pointed out that that was probably not the last time that neurostimulation has been associated with a lot of bull. So let me tell you about the 3 kinds of neurostimulation. Vagus nerve stimulation is the oldest. It's been around for 20 years, so we've done it for a while. The other 2 are newer. This is your vagus nerve. in your neck. You have one on the left, you have a one on the right. The one on the right has more control going down of the autonomic parasympathetic function, which controls your bronchioles and your digestive tract and your stomach and slows your heartbeat. The one on the left has some downward flow as well, but has more that goes up to the brain, which is what we neurologists are interested in, because it means you can control the electrical activity of the brain to some extent by stimulating the vagus nerve. I suppose you could say, therefore, that what happens in Vegas doesn't stay in Vegas. Puns are not going to get better throughout my talk, so I'll warn you now. So the idea is that the vagus nerve gets stimulated and it affects the EEG pattern, what we call desynchronizes things. And the brain cells have to be firing highly together synchronously during a seizure. So desynchronizing them helps to break up the seizures. And the effects tend to last 5 to 10 minutes of stimulation, so to save battery life. It originally came into effect with a routine being on for about half a minute, then off for 5 to save battery life, then on. So how well does that work? Well, in the blinded trials, I don't know which side to favor. Here down is better because it means more of a seizure reduction compared to baseline. And you can see that with high stimulation, there's more reduction than with low stimulation in 2 trials, and that difference was statistically significant. Now, these were blinded trials, which are the gold standard of what like the FDA and we medical scientists use to decide if something really works. Blinded is probably a bad word. We don't actually put out anybody's eyes to do these trials. It just means that neither the doctor treating or the patient knows if they're on a real treatment or a placebo treatment. And that keeps everybody honest, because even unintentionally, you might really want to get better and feel that you're getting better when you might not be. So better than placebo. Then how much better? Well, for every type of neurostimulation that I'm going to talk about, it seems to take time, so that in the first 3-4 months, you may only have about a 1/3 reduction of seizures. But if you go on another couple of years, it becomes a half or 2/3. We think that the stimulation is making some long-term changes in brain. And I won't talk about what they are. We have some theories. This, by the way, is very different from stimulation used for Parkinson's disease or tremor, the movement disorders, where the patients can get better right in the operating room. So it's a different kind of thing. I wish our seizure patients got better right in the operating room, but we often have to counsel. It takes some time to get better. A new wrinkle involves not just stimulating every 5 minutes, but making it possible to do something between those stimulation times. And now with the newest stimulators, there are 2 things you can do. One is you can have a magnet, and wear it on your wrist. And if you swipe it across the stimulator when you feel in your chest, when you feel an aura, then it will start a stimulation right then. The other is taking care of the observation that most people have increased rate right at the start of a seizure. And the vagus nerve stimulator is in the chest, so it can pick up the heart rate. And if it goes up, it can put a stimulation right there, as well as the other times. So this is actually just showing an example of that, where heart rate goes up. It's a little hard to see, but it goes up about 20%, and the stimulation comes on. And in this case, a seizure is stopped. Every treatment we have, every drug, every surgical procedure, every neurostimulation has side effects. And you make a trade-off, you do a negotiation of which is worse at the given moment in time in clinic, the seizures or the side effects. So the vagus nerve stimulation side effects are mostly throat side effects. people feel it. It stimulates a nerve in the throat, and it makes people talk hoarse when the stimulator is on, kind of like the Godfather. Sometimes there's a little bit of coughing, but if we build the intensity of the stimulus up over a couple of months after implant, people usually get used to this. There is one serious side effect. It can make sleep apnea worse. And that doesn't even always respond to CPAP machines. So someone who has sleep apnea might be cautious about getting a vagus nerve stimulator. But not every side effect is bad. Rarely, most of them are. But sometimes there's a beneficial side effect. And in this case, it was found out that the vagus nerve stimulator sometimes helped people's depression. This is big because 50% of people with uncontrolled epilepsy have significant depression. Of course, it's not only messed up the life, but there are biological links between seizures and the happy juice neurotransmitters like dopamine that are responsible for controlling mood. So some of the patients were coming in all of a sudden with smiles on their face in clinic. And so we would say, oh, I guess your seizures are better. And they'd say, not much, but I'm happier. So it was decided to do a trial in mood, and the FDA thought it was significant, so they approved it for depression. Okay, so that's vagus nerve stimulation. Let's move on to number 2 of 3, which is responsive neurostimulation. This is kind of a Buck Rogers sort of device that a surgeon such as Dr. Buch would implant in your head, and it would be a marvelous miniaturized EEG machine that would be about as big as this clicker that I have in my hand. And that machine could continuously record the EEG, could detect when the electricity showed a seizure was starting, and could then deliver a stimulation to 2 wires that could be placed anywhere in the brain. Each wire has 4 contacts. So detect the seizure and then counter shock it. It's kind of like what the cardiologists have been doing for decades with the automatic defibrillator in the heart. Detect when your heart goes into VFib and give a shock to stop it. In this case, you're giving a shock to stop the seizure. We've also found that there are little electrical seizures that happen all the time in people with epilepsy that they don't even really feel. But maybe it has a little bit of a loss of attention effect or some slowing down. Anyway, this device picks those up as well and gives shocks to those. And over a while, there have been enough stimulations that it seems to chronically reduce the number of seizures so that not as many happen that have to be stopped. And that's a pleasant surprise. Here you see an example of this. It's electrical activity in the brain, and you can see the buildup of a seizure here. It's detected, a stimulation occurs, and a seizure stops. That doesn't happen every time with the stimulation, but it does happen enough that it's worthwhile. Plus, we can access online how many of these seizures were seen, and it becomes a very good long-term monitor for really keeping track of how many seizures that patient has. And if we give a stimulation and it doesn't stop the seizure, we can reprogram the device from a paddle outside the head to maybe change the nature of the stimulation so it's more effective. So this is a very useful, almost revolutionary device, and a great recorder for recording and logging seizures for us, since seizure diaries are not really very effective for that, the ones people write in. But it does have the drawback that you've got 2 wires that you can put someplace, and you have to know where to put them, which means you have to know where the seizures come from, and there can't be more than 2 places, or this doesn't work. This is the effectiveness in the clinical trial, the blinded clinical trial that led to approval. Let's say you start with a certain number of seizures per month, 35 per month. We're talking about pretty severe epilepsy here. And the device goes in and, right away there's improvement. Stimulator hasn't even been turned on for the first 1 or 2 months in these trials, and yet the patient is better already. So maybe there's some effect of just putting the wire in the brain that causes the seizures to go down. Or maybe it's something less interesting, which is just that patients don't go into a surgical trial when they're doing well. So they wait for a moment when they're doing badly, and then the next measurement's probably going to be better. That's why you need a control group, a blinded control group. And here you can see that things split so that the group that has the stimulation active continues getting better, whereas the placebo group doesn't get much better. Again, over time, it improves. The higher the bar is, the better it is. So by 3 years of stimulation, in a study done by my colleague, Dr. Razavi at Stanford, you're up to about 80% improvement in seizures. That's not chopped liver. That's a significant improvement in seizures. It's not a cure. About 15 to 20% of people become seizure-free for 6 months or more. And again, these are people who are having 30, 40 seizures a month beforehand. So it's a significant effect, but it's not a cure. And it takes some time to develop. This is just showing how many people are seizure-free. They are the happy ones. Again, everything has side effects. They're usually not too bad with these neurostimulation devices. The vagus nerve stimulator and the deep brain stimulator that I'm going to talk about in a moment, the stimulator goes in the chest, like right about where I'm pointing. Under the skin, of course. Everything has to be under the skin or you would get infected. And then the wire goes over the clavicle, under the skin, behind the ear, to the top of the head, and through a couple of drill holes in the head. But for the RNS stimulator, they decided to build the stimulator right into a skull bone, put a little metal pan in there, and the stimulator sits in it, so that when the battery runs down from these devices, which is typically anything from 2 to 10 years, 5 years might be typical depending on the setting, you don't have to replace the wires. You just either have to make a cut and replace the stimulator in the chest, or you have to make a cut in the scalp and replace the stimulator in the pan, and just pull out the 2 plugs of the 2 wires and plug them into the new stimulator. You get some infections, and a few people get more seizures with these devices, but most get fewer seizures. So now we come to the third approved stimulation. Remember, we did VNS, vagus nerve stimulation, responsive neurostimulation, where the stimulator is put on top of the seizure focus or 2 seizure foci. This one is what Dr. Buch was talking about earlier, where we don't go for where the seizures start, but we go for the main crossroad highway where they spread, to try to block the spread of the seizures and have it die down before it gets bad. And this is done by putting wires, stereo EEG wires, in the thalamus, if you will, the control center, the switchboard for information coming in and mostly going out of cortex. All our senses go through the thalamus, except for one. Trivia question. Which of our 6 senses doesn't go through thalamus? Does anyone know, besides the doctors in the back? Yeah, I know you know. Yeah, that's right. Smell. Good for you. It goes straight from your nose, the olfactory bulbs, right into the brain. Probably because it's like the most important primitive sense. And thalamus is mostly developed in order to be a way station for our advanced neocortex. Okay, that was like an aside. I don't know why I'm talking about it. But you can see that these wires, which can be implanted also by robots now, have 4 contacts at the tip in order to enable us to pick the the best one to stimulate in the target after implant. And you can see the dots where they go in. So the effectiveness of this looks very much like the graph that I showed you for the responsive neurostimulator. And in fact, they are almost equal. These are two, I would say, equally effective treatments, both of which have about a 30 to 40% seizure reduction in a blinded phase at 3 months and have about a 60 to 80% reduction as you go for a couple of years. This is what convinced me it really worked. Here we have the treatment group, and lower is better, 40% reduction, versus 14% reduction with the placebo group. And we turned the placebo patients on here without them knowing that they were in a placebo group, and their seizure frequency quickly dropped down to what the others did. I found that persuasive. Even when it doesn't stop all seizures, it reduces their spread, it reduces their severity. There are less falls, there are less injuries. A few people become seizure-free, 18% for at least 6 months, 8% for 2 years, 9% for multiple years. Are they off medicines? Not usually. They're usually on fewer medicines. As much as people tend to dislike side effects from medicines, if they're seizure-free, if they're driving, the idea of going off medicines and maybe starting to have seizures again, give up their license, is kind of scary. So people tend to stay. I haven't been paying attention to Medtronic in the back. This is the company that has pioneered all of this deep brain stimulation stuff that I'm talking about. They tend not to want to risk having seizures again. So I sometimes get that, well, gosh, you've been seizure-free for 2 years. Do you want to try to go off your medicines? The answer might be no. Okay, there are side effects from stimulating the part of the thalamus, which is the front part. The anterior part is what we chose to stimulate. The two of them that I think are most annoying to patients are the possibility of having a worse mood or a worse memory. Because you're going to hear in the next talk after the break that, you know, memory problems are one of the most annoying things for people with epilepsy. And this circuit that we're stimulating is part of the memory and emotional circuit. It's also part of the most seizure-prone circuit in the brain. And we haven't really been able to separate those out completely, except I will say that most people don't have significant mood or memory problems, but a few do. And if somebody is seriously depressed, I wouldn't use this therapy. The scariest, and I don't mean to scare you, but I've learned that most people with epilepsy want to know, the scariest side effect is death. And, you know, thank heaven seizures rarely cause death, but sometimes it causes a heart attack or a heart stoppage or excessive, you know, breathing stoppage. And that's called SUDEP, sudden unexplained death in epilepsy. It is rare in people with epilepsy in general, but it's less rare in people who have continued uncontrolled seizures, particularly the tonic-clonic, the grand mal seizures. So seizure control helps reduce the risk of SUDEP, and neurostimulation, any of them, vagus nerve, responsive neurostimulation, or deep brain stimulation, cuts down the rate of SUDEP very substantially. Basically saves lives. So, you know, I'm often asked, which of these do we recommend? And Dr. Buch can attest that in our seizure conferences every Tuesday at noon, we spend an inordinate amount of time talking about, oh, should we do RNS? Should we do DBS? Should we look to see if there's something to laser out? Should we put depth wires in? But I've grown tolerant of that because it's all a sign now that we have a lot of possibilities to do things, even though we often don't quite know how to choose among them. But we didn't have any of those possibilities before. So in the blinded phase, VNS, we'll do that first in blue. Reduced seizures by about a third in the blinded phase, a little more for RNS, not the same for DBS. And then I said over time, things get better. And at this point, RNS and DBS are a little better, and the percentages of people who become seizure-free are a little bit better. But RNS and DBS requires putting a hole in your head, and VNS requires just putting a hole in your neck and your chest. So it's less invasive, and you don't run the risk of having bleeding from the wires in the head from RNS or DBS, or infection that might infect the brain, although that's rare, infection infecting the brain, and so is the bleeding. In the original clinical trial of 110 patients, we didn't have any clinically significant bleeding. But it does happen. So in a way, VNS may be slightly less effective, but might be a bit safer. And yet it's more annoying because they feel it in the throat, and then you don't feel anything with these brain things when the stimulator comes on. So how am I doing on time? Do I have 5 minutes? That's all I need. We're trying to make our neuromodulation better. For example, as Dr. Buch said, by customizing it to how your seizures spread through the brain. Because sometimes the standard target that the FDA has approved may not even be on the pathway of spread for your seizures. So we're using some of our depth wires to look at that. But what I really would like to do is to make it non-invasive. So we didn't have to put holes in the skull at all to do it. That would make it really much lower risk. So one way is with magnetic stimulation. That's me, volunteering for stimulating of the head, and also it eliminates the HIPAA problems with showing a picture of the patient. With my setup in my lab for transcranial magnetic stimulation pulses, that requires some big machines that I couldn't wheel around into the intensive care unit. So lately I've used something called transcranial direct current stimulation, which is basically just a handheld battery-powered device that can be connected to some sponges that are put on the head over where seizures come from. And that seems to actually potentially reduce seizures, even in some particularly sick patients from seizures. So that's called TDCS, transcranial direct current stimulation. This is TMS, transcranial magnetic stimulation. Now, this is also used by people outside the medical sphere sometimes because they feel if they stimulate certain parts of their brain, they do better on tests. Actually, there is data that it can affect memory. It's used by athletes to sometimes improve performance. I'm talking brain stimulation, colloquially called brain doping. And I don't believe the Olympic Committee has any way to test for that yet. But, as someone who does this professionally, I would say, do not go on YouTube to see how to build your own brain stimulator. You can, it's there. Do not stimulate your own brain electrically without a medical device. People do, but I don't recommend it. That's the transcranial direct current stimulation, what it looks like when you have a patch on your head and just a little box. And this is just to show seizures getting better with the stimulation. And then the last modality to talk about, Dr. Buch just mentioned as well, which is focused ultrasound. This is a marvelous new technology. It can be focused much better than anything else that I've told you about in neurostimulation. It uses sound waves, but it's sound waves of such a high frequency that even your dog doesn't have a chance of hearing them. Still, it has high energy, and the beams can cross and focus on any point deep in the brain. It's possible to use it to do surgery. This is a paper I was involved with where instead of putting a stimulating electrode in the anterior thalamus, we treated it by using very high intensity focused ultrasound to just burn a little hole in that part of brain. Why did we do that? Because there was a stimulator, a Medtronic stimulator in there before that helped the seizures a lot, but the patient got a scalp infection at the entry point and it had to be removed and he didn't want to put it back in. So this was an alternative that a courageous surgeon, Dr. Vibor Krishna, tried this pioneering technique of doing focused ultrasound instead of the stimulator. And he did it on 2 patients, red and blue, and you can see what happened to the seizure frequency when we did it. Now, both patients had some memory problems after the procedure, so they were not huge, but significant. There was a price to be paid. But I'm not only talking about making holes in the brain with high energy ultrasound. There's a way you can use low energy ultrasound, like is used in diagnostic testing, and it still seems like it may affect the excitability of the brain without actually damaging any brain tissue. So when we know where there's a seizure spot and the patient doesn't want to have it taken out or lasered out by surgery, I hope there's going to be a possibility of focusing ultrasound beams on it just to reduce the excitability. Now, this is totally new, so it's not proven yet. It's not accepted therapy. It's approved for doing research testing under FDA guidance. I just got FDA approval to try a couple of patients with this in the near future and show that it's safe. There have been 20 who've been done in the world, and so far it seems quite safe. Will it be effective in the long term? How often would a person have to come back in order to get additional treatments to keep any benefit going? These things we don't know. But this is my quest now in the twilight of my career, is to try and find devices, hopefully safe, non-invasive devices, not involving drugs, to treat seizures that can't be treated otherwise. The National Association for Epilepsy Centers keeps a tally of procedures in about the 215 highest level 4 epilepsy centers in the country. And sometime 2 years ago, we crossed the number of surgeries. The total number of surgeries by cutting something out or lasering it out was 3,227 in the US. And the total number of VNS plus RNS plus DBS was 3,399. That was a couple of years ago, 22. I can tell you this is growing. This is probably growing too, but this is growing faster. So we're doing more and more neuromodulation. The landscape has changed. Conclusions: neuromodulation is in its infancy, but already with a big impact. VNS, RNS, DBS have similar effectiveness. Maybe RNS and DBS, the ones in the brain, make more people seizure-free. VNS is less invasive, but can irritate the voice or throat. You don't want to put it in an opera singer. RNS has a good safety profile, but requires localizing where the seizures begin. RNS can chronically record and log seizures. DBS, on the other hand, you might be able to do away with a stereo EEG procedure to figure out where to put your RNS electrodes, but DBS can adversely affect mood and memory. So all 3 of these, I think, are complementary to each other. The main point is not to be complacent. You know, if your doctor is telling you, well, you only had 2 seizures last month and you didn't fall and break anything, so let's just keep going. Be aware, like those annoying commercials you always hear on TV. Ask your doctor about what else can be done. Or if I could channel Yoda, choose wisely, but most of all, choose. I'm done. Thank you.
Dr. Fisher? Dr. Fisher, there was a Zoom question. One of our attendees on Zoom is asking, could a drop of heart rate also cause a seizure?
Could a drop of heart rate also cause a seizure? Well, if it dropped enough that your brain didn't get good blood flow, it could cause a seizure. But I mean, it almost has to stop for a matter of, 30 seconds or a minute before that happens. That does happen in some patients. And they don't get treated, if that's the case, with anti-epileptic medications. They get treated with a cardiac pacemaker. That cures the problem. Yep. Oh, okay.
Oh, hi. Just one comment on, it's entertaining and informative as always. Dr. Fisher,
thank you.
thank you. Patients I had that were VNS candidates, I had several that were typical Silicon Valley types, and they had multiple medications, high dose, and still having some seizures. And had learned to live with the epilepsy, but they said, if I could just lower the number of medications or the dosage, that would make a huge difference in my ability to program, computer programmers, things like that. And so that's kind of another indication. The expectation you're going to be cured is fairly low, but it's still there. But you can save on your medications and clear up your thinking a bit too.
Yeah, you're right. It is so important to set realistic goals. If someone, expects that they're going to have a wire put in their brain and they're going to recover from the surgery and then be seizure-free right away, I am sure they will be disappointed. Other? Yeah.
You mentioned that the VNS could go off with an increased heart rate before a seizure. Would that be any increased heart rate? For example, if you're exercising, would the VNS come up?
It's a good question. You can set, and we do, when we have that model VNS, which is the model we always put in now. Is it a 20, 30, 40, 50, 60, or 70% increase in heart rate that it has to go up? And we basically determine that by looking at how much the heart rate goes up in that patient's previously recorded seizures on an EEG, because we almost always have a heart monitor with it. You might set it off with running up a flight of stairs, but usually you wouldn't, because the algorithm takes account of the fact that the heart rate increase with seizures is usually much more sudden than it is with exercise, unless you're doing a weird aerobic kind of exercise. And anyway, if it goes off when you're exercising, it's just an extra stimulus, which we often turn it from every 5 minutes to every 3 minutes or every 1.1 minutes anyway. The only consequence of that is running the battery down faster. Other questions? Yes. Here, I'm close to you. Just talking to this.
Can they feel like when it goes off?
The vagus nerve stimulator, yes, they do feel it. And I can, because they start talking like this. Yeah, people are welcome to share their own experiences. I won't ask it because I want to respect privacy, but I realize I'm supposed to be the expert, but I don't have any of these devices in me. I've never had a seizure. So there are people in this room who are actually more expert in what I'm talking about than I am, and feel free to speak up. Any other questions? So let's go to your much needed break. And I encourage you very much to visit the booths and get information about these new treatments that we have there on the side. endorsed or supported in this program by Tri-Valley or by Stanford. Their relationship is with the Epilepsy Foundation. So yes, thank them for being here. This is Dr. Niyatee Samudra, who, as you heard in the beginning, has done a fellowship both in epilepsy and in cognitive memory issues. And the possible exception of the complaints about not being able to drive, which I'm going to talk about after her, complaints about memory, I think, are the main thing I hear in clinic. So it's like really important. Show is yours.
Thank you so much, Dr. Fisher. Yes, I am very excited to talk about this topic, which is pretty wide ranging. And I want to try to cover as much as I can in the time that I have, but we know this is a broad topic. As Dr. Fisher mentioned, I'm in the Division of Memory Disorders and Epilepsy both at Stanford, because there really is a link between these two conditions. I don't have any disclosures. And so I think we've alluded a little bit to this, kind of over the course of the multiple talks that came before mine. But, why are we even having this conversation? Why bring up the question of cognitive and mood disorder in epilepsy? So the revised definition of epilepsy in 2005, defines it as a brain disorder that's characterized by the enduring predisposition to generate epileptic seizures, yes, but also by the neurobiologic, cognitive, psychological, and social consequences of having epilepsy. And so for me, what that means is that these symptoms are really intertwined deeply with the experience of having epilepsy. And that's why we keep hearing that they matter so much to people with epilepsy. So I personally do have a special interest in understanding and addressing these aspects of epilepsy better. Overall, I'd like to start by talking a little bit more about cognition, a little bit more about mood and behavior, trying to sprinkle in some of how neurologists and epilepsy specialists would think through and address these problems when patients come to them, and what are the resources for patients. So let me start by talking a little bit about what cognition even is. A lot of times in clinic, I'll hear that people don't feel like their memory is in great shape, or they're having trouble with memory specifically. And so some of the things I'll hear are things like, I can't remember what someone just said in the middle of a conversation. I'm losing, my cell phone, wallet, keys so much. I'm having trouble with concentrating. Sometimes if people ask me to do complex things, I just feel really overwhelmed just with multitasking, or I have trouble finding words, So I would say that memory is one part of cognition, that it's a broad, interconnected set of functions and skills. And it's actually defined as all different forms of knowing and awareness. So perceiving, remembering, reasoning, judging, imagining, and problem solving that are all kind of interrelated. So I like to think about a few different domains or areas of cognitive function. I'll start with memory and learning. And so that's going to be, the ability to really retain information over time. And that depends on a bunch of different things. So first, in order to make a memory, we have to encode the information. We have to store it over time, and we have to be able to retrieve it when it's needed in order for it to be useful for us. And as you can imagine, there's a lot of different ways that this process can go wrong. And then there's executive function. That's another really big area that I hear about a lot that's slightly different than memory. So that's going to be, multiple different things, including the ability to pay attention and focus, not be distracted, concentrating, but there's also processing speed, like how quickly can we think through something? And even the ability to inhibit your reactions to things, that's part of executive function as well. And so these functions are broad, interconnected. They may depend more, roughly speaking, on the frontal lobes of the brain. And we think, roughly speaking, that memory depends more on the temporal lobes of the brain, but they can affect memory because executive function affects your ability to encode the information initially, retrieve the information when you need it, and manipulate the information as you need to in the short term. So working memory. And there's other areas. So another big region, of cognitive function that I think is important is language. And you might hear the term aphasia, for difficulty with language. And, trouble with naming or finding the right word could be the most common sign of aphasia, but there's a lot of different subtypes with different symptoms. And then other areas are going to include visual spatial perception and motor planning. And, these also can conceivably be affected in epilepsy in certain situations, but I often hear more about the first three, the memory, the executive function, and to some extent, the language. So how often do people with epilepsy have cognitive problems? So 20 to 50% of patients with epilepsy say they have trouble with their memory. It could be more. I'm not sure. I think we don't always have the best ways of measuring these things. But what we know is that trouble with cognitive function has a major impact on quality of life. And in a survey of about 1,000 patients with epilepsy, 40 to 50% felt like their epilepsy affected their memory, concentration, and their ability to think clearly. There's also a question of, trouble with cognitive function that may start before the seizures start. So there might be a higher incidence of ADHD, for example, in people that have epilepsy than in the general population. And 5 to up to almost 50% of people with autism also have epilepsy. So what is the effect of seizures on cognitive functioning? We know that memory can be affected during and after a seizure. And if people have had seizures for a longer time, then their cognitive performance could actually be worse. And it's possible also that where your epilepsy comes from can determine the kind of cognitive problems you have to some extent. And we've talked a lot here to this point about how to localize someone's seizures or kind of understand more clearly what part of the brain where they're coming from. And so I think we know that, for example, temporal lobe epilepsy can have a big impact on memory, so ongoing temporal lobe seizures, but it may not only be memory. Folks with temporal lobe epilepsy may also have trouble with, working memory, their executive function. And then people that have seizures that start from the front part of their brain, frontal lobe epilepsy, you might assume that they would only have trouble with executive function areas. But actually, because there's a relationship between these, they may also have trouble with their memory too. And then there's generalized epilepsy, where we think maybe not that seizures start from all over the brain at once, but they start from broad distributed networks in the brain all at once. And so they can also have a combination of these types of symptoms. And then also what we don't understand so well, but is an area of active research, is, so what if someone isn't necessarily having a seizure? What if what they're having is frequent sparks, like that a person has seizures in a specific part of the brain? For example, temporal lobe spikes and sharp waves. These may actually have, if someone is having them frequently, an impact on memory. And that's an area that we're starting to understand a little bit more about. So memory, the ability to name certain things, working memory and so on can also all be affected by potentially these little sparks, these interictal epileptiform discharges. So this topic, I think, has already been brought up tangentially a couple times here. We talked about the effect of seizures on cognitive functioning, but the treatment for seizures can also potentially affect cognitive functioning. So typically speaking, as a general rule, the older anti-seizure medications have more of an effect on cognitive functioning. And the newer anti-seizure medications, it may be a little bit more neutral or maybe a little bit more positive of an effect on cognitive functioning. But that's not 100% true across the board. And there are some classic concerns with certain seizure medications. So Topamax or a similar medication, zanisamide, for example. Word finding difficulty is a very classic complaint that people have with that medication. Also, it could be that being on multiple anti-seizure medications at once will have kind of an unpredictable effect on memory and on cognitive function in general. So this is why, just as others before me have really emphasized, it's wonderful if you can establish with a neurologist or an epilepsy specialist that you trust and feel like you can have these conversations with, thinking through, is it possible to maybe streamline the medication regimen a little bit, or maybe to switch from an older medication to a more cognitively neutral, newer medication? These are the types of discussions that can and should be had. So then there's other things besides medications that can affect cognitive function in people with epilepsy. We've talked about the impact of continuing seizures. Over time, it does seem like people that have more frequent seizures or seizures that are not well controlled may have more difficulty with their cognitive function. And so that really, getting the seizures under control can be a first step in trying to address some of these problems. Then we can think about, why is this person having epilepsy? What do we know about that? Some people have epilepsy after traumatic brain injury. Others might have epilepsy after brain swelling, called encephalitis. And maybe that condition in and of itself also might have an impact on memory. So that can be a component as well. And we also know that a person's mood can really affect their sense of how their cognitive function is. So, for example, a person that is depressed may be more likely to feel that their memory is affected. It is true that the experience of depression or anxiety can affect the perception of cognitive problems. However, it's also true that depression and anxiety can themselves also affect cognitive function. They can affect processing speed, attention, and some of the other elements that we talked about before. Also, sleep is a really, really critical piece of this puzzle. So, I think that it's not uncommon for patients with epilepsy to have sleep apnea or maybe difficulties with sleep. And so really getting a sense of how someone's sleep is, and if there's anything we can do to improve it, could actually result in an improvement in cognitive function. There's also aspects related to aging. So we know that there can be changes in brain function that happen with age. And over time, maybe as someone who has seizures gets older or there are changes over time, there may be also changes to cognitive function. And it's also possible to develop seizures for the first time in your older years. And for some of the reason for that to be also related to memory and cognitive function. So that is something that if you feel like you're noticing a change to your memory over time as you're getting older, in general, good to bring up to your physicians and hopefully eventually to a neurologist. So this picture is a little bit on the older side and it's a little bit busy, but I like it. So I'll try to walk you through it. In general, it's kind of breaking it down a little bit here where there are factors that are not
No,
so easy to
it's
change
live.
that can impact cognitive function. And they call them here morphological factors. That's kind of what I've talked about. What is the reason that this person may have epilepsy? Whether that's brain swelling or, the result of traumatic brain injury. And then there's something else that we can't really change the effect of, maybe like epilepsy surgery. So that's something that has happened. And then there are cognitive results of that potentially that could occur. And then there's also features that are specific to the patients themselves. So as I was mentioning before, how long a person may have had seizures, for example, could be a part of that. Could it be possible that they have something already pre-existing that was diagnosed before they started to have seizures? And then there are the factors that we like to think about because we can modify them more easily. And so those would be things like changing your anti-seizure medication regimen. Things like if somebody is having trouble with their mood, that's something that we can address and that we can hopefully treat. If someone is having seizures that are not controlled, we have so many things, an armamentarium of therapies that we can use to reduce seizure frequency, which were discussed. And then if someone is having frequent interictal epileptiform discharges, like I said, this is still an area of debate and research, but maybe that's something where in certain cases, suppressing those a little better, could that improve memory and cognitive function? We're not sure. So if you come to a neurologist, as somebody with epilepsy and you say, okay, I'm having trouble with my memory, what are some of the things that that person can do to help? So first, it's a good idea to maybe think through starting out with where exactly is the problem? And so that can be done with formal neuropsychological testing, to really sort of break down exactly in which domain is the problem happening. Okay. And this can be done once, but this can also be done over time to assess, is this a problem that's staying the same or is it getting worse? Because just the fact of staying the same or getting worse can help us a little bit in diagnosing what's the problem. And then, like I was mentioning, just continuing to work on improving the seizure control, thinking about changes to seizure medicine therapy, and then also looking for signs of just other neurological and medical problems. So that's going to be, like I said, sleep apnea, maybe honestly, someone that's having trouble with their hearing, that's going to potentially affect cognitive function, their vision, and then looking into whether it's possible that that person is developing another condition that affect their memory. These are the steps that neurologists can take. And then for patients, there are some resources for you if you have memory problems and epilepsy. And a lot of times, there's a possibility of a referral to other medical professionals like speech and occupational therapists who work with folks that have memory problems and can help kind of optimize their daily functioning a little bit better. So both for rehab and also for kind of helpful cognitive strategies. And this is also a little bit of a busy slide. I apologize for that. But there's a program called Hopscotch, a really fantastic program that's actually a self-management program that was devised by Dr. Barbara Jobst at Dartmouth and her colleagues there. And effectively, it's a self-management program that lasts for several sessions and actually teaches cognitive skills and kind of ways that patients with epilepsy can help themselves a little bit more, learn the skills that they need to improve their daily functioning. So I'll switch gears now to talk about mood and behavior symptoms in epilepsy. And I think, not every person with epilepsy will have these, but they are very common. So they may happen in about 25 to 50% of people with epilepsy and maybe more. As I said before, I don't think we necessarily have the best ways of measuring these types of things. It's really important to identify these early because they have a significant impact on quality of life. And as I was mentioning before, these symptoms can affect your feeling that there has been a memory change. So there is kind of this relationship between the two, mood, behavior, and cognitive function. So what kinds of symptoms are we talking about that patients with epilepsy might have? Most commonly, it's going to be depression. That can be up to 23 to 25% of patients. And depression, as we know, is not just feeling sad on occasion, but it's going to be a disorder that's associated with these really persistent feelings of sadness and loss of interest, among other symptoms. Anxiety is also really, really common, across the board in all people, but particularly in patients with epilepsy. And there are several different kinds of anxiety disorders. Again, you can be anxious, and that can be a temporary thing and sometimes even appropriate for the situation. But an anxiety disorder is going to consist also partly of worry that doesn't get away, gets worse with time. And there can be different kinds. So there could be panic disorder, PTSD, generalized anxiety disorder, different ways that anxiety can present and be debilitating. Other symptoms that are a bit less common, but still ones that we see in epilepsy, are going to include bipolar disorder. And that's going to be a disorder that is associated with kind of these unusual shifts in a person's mood level, energy level, and activity levels. And there can also be psychosis, which is a disconnection from reality or a disconnection in terms of your experience of reality. You may experience delusions, beliefs that are not true, or hallucinations, like experiences of things that are not there. And it's also true that there is a possibility of experiencing specifically suicidal thoughts and thoughts of self-harm. So, what is the relationship between seizures and mental health changes? So, depression and epilepsy have a close relationship with each other. We know that epilepsy is associated with depression, but it may also be true that patients with depression have a higher risk for having epilepsy as well over time. And I think we've spoken a bit about this, but the brain pathways that are involved in epilepsy are also potentially involved in mood disorders and cognitive functioning. So these are all the same brain, and they can have dysfunction in slightly different ways, but these dysfunctional areas can cause related symptoms. And it's possible that depression may be more common in temporal lobe epilepsy, but certainly we can see depression in all forms of epilepsy. There can also be a relationship between the timing of mood symptoms and seizures. So people can experience symptoms before a seizure, like several days before, for example, that give them the sense of, okay, maybe something is coming. They can experience changes after a seizure, and then also between seizures. So speaking too about the treatments for seizure and mental health. So some anti-seizure medications do have more of an association with worsening mood, but others can be more so associated with improvements in your mood. And that's another place where talking with your doctor about if you're having persistently low mood is a good idea. In the short term, after epilepsy surgery of certain types, you can have changes in mood that are negative, and they can be persistent for some people. And then, as we've discussed before, some therapies for epilepsy that are not related to surgery, neuromodulation therapies, particularly vagal nerve stimulation, can improve depression as well. So overall, if you're experiencing all or any of these symptoms, just bringing up changes in your mood or emotions to your medical team. And, the question is when to do that. I think anytime that you're concerned is a good time, but also thoughts, emotions, and behaviors that just feel out of control, and particularly any thoughts of hopelessness or self-harm. These are things that your medical team needs to know about, especially because treatments can be very effective. That's going to be medication, psychotherapy, social support, all of these things. Lifestyle management. So I think previously some folks had asked questions about exercise and the benefit in seizure control. And there is actually benefit for exercise in seizure management, but there's also a benefit, of regular exercise to cognitive function and also to mood function separately. And avoiding drugs and alcohol, getting adequate sleep, and trying to minimize emotional stress to the extent possible can help with all of these symptoms. So overall, I think my takeaway here would be there are resources available. Talk to your doctor about what your specific concerns are to come up with a plan that's individualized to you. They may seek the help of psychotherapists, psychiatrists, neuropsychologists, memory specialists, occupational or speech therapists to try to come up with a plan for you. There are support groups through the Epilepsy Foundation and crisis lifelines that are available, like 988. So lots of different resources that are available. And overall, I just would want you to take away that cognitive, mood, and behavior symptoms are common in epilepsy because they relate to the fundamental cause of the disorder, that they are very interconnected. And they can also have a significant impact on quality of life. And it is important to talk to your doctors about your symptoms because everyone and every person with epilepsy deserves high quality care for all aspects of their brain health. So it's not just about seizures, It's also about the other symptoms that you experience. Okay. Should we?
Dr.
think there's
Samudra,
questions,
there was
so-
one question over Zoom, and then I'll go to the
perfect.
audience.
Dr. Samudra, there's a question about the relationship of seizures and autism spectrum disorder and how people might be affected either if they're high or low functioning.
I think that's a really good question. We know that people with autism are higher risk to have seizures. And there are certain syndromes that can go along with autism and seizures. Some of them are genetic with a known gene-related cause, and others not so much. And I would say that in many cases, having a high index of suspicion for seizures in patients with autism is really critical, because treating the seizures can really help with quality of life. There are a lot of different kinds of seizures, as Dr. Roberts previously, kind of alluded to. Some can be, very clearly identified, and others just not as obvious. So yes, there's a relationship. It's a pretty strong one. It's stronger than the general population. And if you have any concern that your child or your loved one could be having seizures and they have autism, definitely getting that assessed is a good idea. I think.
Can you please go back to the slide with the resource numbers?
Yes.
That would be great. Thank you.
100%. Oh yeah, let me stay on this slide. Of course.
Thank you. So you mentioned that there's a high overlap between the percentage of people with epilepsy and the percentage of people with ADHD, and with medication being the gold standard of treatment for ADHD. Are there psychiatrists that specialize in epilepsy? Because a lot of times a lot of providers will refuse to prescribe any sort of stimulants because of the epilepsy.
I really love this question. We actually have someone in our division, Dr. Kim Metter, who has studied this at some length. And, it is true that there has historically been a concern about prescribing stimulant medication in patients with epilepsy. We now know that, this is something that is not a no-go. And in fact, managing ADHD is going to be good for seizure control also. So it's definitely something to ask physicians about. And to your question, are there psychiatrists that manage and treat epilepsy? Not so much necessarily, typically, but I think if there is a way to connect a psychiatrist with a neurologist, that manages, maybe an epilepsy specialist, I think that's where, it could be helpful to have those types of conversations. And both stimulant and non-stimulant options for ADHD are options.
I think might be worth emphasizing the point, since there is this relation between the seizures and the cognitive and emotional aspects, that the longer these go on, certainly epilepsy, the longer you have it, the less responsive it is to treatments. I think our epileptologists can, pontificate on that. So I think the point is, if you have seizures or these emotional problems that go on, seeking help sooner rather than later may result in better outcomes in the long run. Do you agree?
Yes, I agree completely. In all situations, it's not to say that if problems go on for a long time that they're hopeless and they can't be resolved, but addressing emotional problems, especially as early as you can, is a really good option. The consequences of untreated depression are pretty significant, or untreated other psychiatric comorbidities are pretty significant. Yes. Yes. Okay. All right. Thank you, guys.
Applause. I'm sorry that we can't get to all the great questions from online. The DMV was going to talk about seizures and driving, but they're busy figuring out how to raise your bridge tolls further. I've decided to take over and give that talk. I spent a lot of time counseling patients in clinic about driving safety issues. I've been on 2 medical advisory boards for DMVs in 2 states, and I've been a expert defense witness in 4 unpleasant trials that involve seizures and car crashes. So I actually do deal a lot with this issue. Some of you may be old enough to remember George Burns and Gracie Allen. He lived to be 100, and he said, "I want to die peacefully in my sleep like my grandfather did, not screaming like the passengers who were in his car." Okay, so I'm going to make a couple of points, and I think I'll try to do this in an abbreviated fashion. One is that, sure, having a seizure at the wheel is a risk, and it makes the risk of crashes higher, but not that much higher, and much less more higher, if I can mangle the language, than many other conditions which are tolerated by driving regulations. And then I want to let you know what the actual rules, regulations are in the state of California and how most doctors look at them. This shows in California that lapse of consciousness disorders, the font is small, is by far the most common reason for medical suspension. Here's dementia, diabetes, mental, whatever that means, neurological, which I think would include most lapses of consciousness disorder. So in the beginning, there was total prohibition of anyone who had epilepsy to drive, and it's gotten progressively more liberal. Here's a tally of the causes of fatal crashes a number of years ago, but it was the best paper I could find. Seizures were 97 out of 44,000. And you can look that diabetes, heart problems, or more, alcohol-related, 12,870, and drivers under 25 years old, 10,000 of the fatal crashes compared to 97 of people with epilepsy. So, maybe we shouldn't be restricting licenses of anyone in this room unless you're under 18 and male. The risk ratio is a little bit higher, 1.33 compared to baseline, not much. Plus, not all blackouts at the wheel are due to seizures. Some are fainting, some are insulin, some are heart conditions and strokes. And this pie chart doesn't even include the number of people who fall asleep at the wheel, which is big. Furthermore, only half of seizures at the wheel lead to crashes. So here's a sobering statistic. The driving accident rate in the US for women with epilepsy is lower than for men without epilepsy. Yep, that will be my only feminist slide of the talk. So how do we handle this in a regulatory sense? People who are at high risk for seizures should not drive. People who are at low risk for seizures, the kind of risks that we accept in others in the population, should be allowed to drive. At least that's my view. So how do you decide that someone is at a high or a low risk of seizure? I can present dozens of papers that look at hundreds of factors that determine a person's risk for having more seizures. But a state regulatory agency can't deal with that kind of complexity. So every one of the 50 states in the US just uses the seizure-free interval to determine when someone can drive. How long has it been since your last seizure? And as you know, of course, every state is completely consistent in that determination, correct? No, I can't sell that to you. I'll show you what the variance is in a moment. So if you have to pick a seizure-free interval, typically the states are picking 3, 6, 12 months or 2 years as a seizure-free interval. And some states leave it open to doctors' opinions, which turns out to be the most variable feature of all. However, if you look at the probability of having further seizures after you've been seizure-free for X period of time, you can see that there's kind of a flattening of the curve after 3 months. So yes, you definitely might have a seizure at 4, 5, 6 months being seizure-free. But for the most part, you capture a lot of the risk with people who can be seizure-free for 3 months. So here is the actual DMV rule, which I took from their manual online. The department may, this is California, the department may suspend or revoke the driving privilege of any individual who has a disorder characterized by lapses of consciousness or episodes of marked confusion. I have the latter even on the good days, so it's a little ambiguous. A current medical evaluation of the individual provided by the individual physician as authorized provides information regarding, and this basically is telling what they're going to consider on the form that we write to them, or if it comes to a medical advisory board meeting, they'll look at the diagnosis, when it came on, when the last episode was, what the frequency was, what the stability is of the condition, any associated manifestations to medication routine. Now, they don't want to know about this at the time of suspension. They just want to know how long has it been since you've had the seizure. But you can make appeals, and then a medical advisory board will be called to consider your case. And those are the kinds of things that a medical advisory board considers. So you can see a map of which states have 3 in purple, 6 in green, 12 in blue months seizure-free intervals. And yes, your glasses are fine. You're not seeing triple at California because here the DMV says that they will consider either 3, 6, or 12 months of suspension of the license. Usually their default is 6, but with the doctor's recommendation on their form, they will commonly go down to 3. There have been a few cases where data, most of this stuff is data-free and just opinion, but a few cases where data has come in. So this looks at the rates of fatal crashes in different states that have different seizure-free intervals. And the one that's 3 months that I circled in red actually has a lower crash rate than certainly the flexible one, and to some extent, even the 6 and the 12 months. So it's not like the shorter the time, the more fatal crashes you have. There's no data to say that that's the case. And I was working in Arizona when the state changed the law from 1 year seizure-free to 3 months seizure-free. So together with one of my colleagues, we laboriously went through multiple boxes of crash records to see if the crash rate worsened when they went from 1 year to 3 months. Anyone want to guess whether it did? It did not. In fact, it was over time when more miles were driven in Arizona because of the population explosion, and still the crash rates were no higher. That's what I say there. There are special circumstances that determine whether you might be able to drive even if you have seizures. They may be non-recurring precipitants. Say you had a seizure in a dentist's chair because of an allergic type lidocaine injection reaction. I would just say, don't drive when you're in a dentist's chair to that. Seizures that are too minor to affect driving, like tingling in the fingers, seizures that have a consistent and prolonged aura that would allow you to pull off the side of the road every time. Seizures only during sleep. Seizures during a physician recommended medication taper. These are all things that I would write on the form where I would say that I would be in favor of medically of continued driving. And by the way, it actually isn't the doctor that determines whether you drive. It's the DMV. We just make recommendations. And that's how it should be, because we don't like the liability if we guess wrong. Commercial driving is a different entity with these big wheel trucks over 26,000 pound weight and lots of axles. School buses and hazardous materials have separate regulation. But then we come down to this interesting category where you drive on a regular driver's license, but you drive a lot. Taxi drivers, van drivers, delivery trucks, salespeople, police and others, Uber, Lyft. You know, it figures if you're driving 14 hours a day, you're more likely to have a seizure when you're driving than if you're driving 1 hour a day. So even though I'm sympathetic to the 3-month rule, for this category of people, I recommend 1 year if they're driving all the time. That's not a law. That's just my own practice. 6 states in the United States require doctors to tattle on their patients when they have lapse of consciousness disorders. It's a criminal penalty for us not to do that. I've never heard of any doctor who was arrested in California for that, but I know of several who were successfully sued, and it came out that they didn't report, and it was really bad for them. So unfortunately, California is on that list. We have to, if someone has a lapse of consciousness disorder, it's not just a seizure, it could be a cardiac event. I refuse to do it for like a simple faint, say in a blood drawing room or something like that, but I hope I never get in trouble for that. We fill out this morbidity report that goes to the health department. Health department hates that. They wish it would go directly to the DMV, but that's what the law says. And then the DMV will send a 5-page form. One of the things I don't like about that is that the required reporting encourages concealment of seizures from patient to doctor. And I think that that ends up having a negative effect because we don't get a chance to make an adjustment that might stop the seizures. I'll skip that. So the American Academy of Neurology made some recommendations. Opposed to mandatory reporting by physicians, favors patients' self-reporting, supports optional reporting where public safety may be compromised. What that means is that if I really think somebody is driving when they shouldn't, and the patient says, if you report me, I'm going to sue you, I'm actually still covered to report if I, in good faith, think that public safety is at risk. Because from the law, that's a higher principle than doctor-patient confidentiality. The DMV, not the MD, makes the determination. Academy recommended 3-month seizure-free interval with modifiers. Restricted licenses they thought should be available, like driving to school or work, and no road test required. Okay, I'll make you work a little bit and then we'll finish. 30-year-old man has a seizure in a dentist chair 10 seconds after getting lidocaine. Workup is fully negative. Can he drive? I think so. 50-year-old man has seizures presenting as tingling and numbness in his left face and hand without loss of awareness. Can he drive? I would say yes. You know, I'd still have to file the forms on this, but I'd make that recommendation. 24-year-old man has a first generalized tonic-clonic seizure with no aura, which is no warning. The seizure occurred while getting dressed in the morning, no history of blankouts, exam, EEG, MRI, urine tox screen, and routine blood work. All are negative. Can he drive? No, not for 3 months. 45-year-old man has had approximately 10 generalized tonic-clonic seizures over the past 20 years, every one during sleep. He should just be advised not to drive during sleep. A 30-year-old woman has seizures with fumbling and loss of awareness, always preceded by 60-second aura of distinctive stomach discomfort. Well, that's a tough one. I won't ask you because I would query not only her, but probably someone who had been in the car with her, whether she really was with it enough in order to get over safely. Because a warning doesn't always mean they can do something about it. Sometimes a seizure makes you freeze up and fumble. 21-year-old man has approximately 8 seizures with loss of awareness per month, despite maximal anti-epileptic drug therapy. Clearly, this is someone who cannot drive until the seizures come in control, if they ever do. So every state, country regulates driving in epilepsy. The risks are about 1.5 times baseline for having a crash, as opposed to being a teenager or anyone who does drinking and driving or falls asleep at the wheel, which are much higher than 1.5. And they are allowed to drive. People with frequent seizures should not drive. States vary in their seizure-free requirement. Individualized exceptions should be considered. And over time, regulations, I think, are improving in becoming more individualized. Maybe to end on a downer, this is the car of one of my real patients. He walked away from this okay. But it's a serious business. So be honest with your doctor. And if you're having uncontrolled seizures that are anything more than minor and non-disabling, then you don't want to be driving. I think I made up some time for Tony Zucker here. Thank you. I'm not going to take any questions, just to make time. It's me getting off the stage, finally.
Hi, everybody. Thanks for being here. I'm Tony Zucker. I'm the board of the Epilepsy Foundation of Northern California. I've met some of you at events, and it's good to see some people I haven't met. And thank you for coming again. For those who didn't make it or want to share this, we'll have a link to this presentation on our website. So look for that probably in the next 24 to 48 hours. And then I want to thank Maureen Hogan in the back there. Thank you so much, Maureen. And Kelsey Fenton. Kelsey's back there, very helpful in planning the event. And of course, we have Rochelle, who did all the technology, and that's much appreciated. And then, of course, we want to thank Dr. Fisher and the Stanford team for being here. Every time I go to a Living with Epilepsy, I learn something new. Yeah, and Dr. Sadat for running the program. Thank you. And then, of course, our sponsors. I really appreciate you, and we appreciate you, and thanks for putting up with my persistence. But you're here, and that's what counts, and you're all smiling, and we see you over and over again at our events, and without you, we wouldn't be able to put on programs like this. So thank you very much. And now I'm going to introduce Natalia Sucher. She's our Director of Operations, and she's going to run you through the slides.
Hi, everybody. Thanks so much for coming out today. Really appreciate it. I hope it's been informative so far. What I'll be doing today is taking you through a run through of our programs and services here at the Epilepsy Foundation. All right. Anybody know what to do? Okay, I guess I'll do some improv before we begin, if anyone can figure out the slides for me. How many? I did the right button. Okay, are we just waiting a moment? Okay, great. Okay, please raise your hand if you're a caregiver or parent of someone with epilepsy. Okay, great. We have a caregiver support group Wednesdays at 4 p.m., 1st and 3rd of the month. Available on our website, and it's pretty helpful. There's about, I'd say, 7 people who come weekly or bi-weekly, and they also have an email thread. They usually ask questions about medications and group gatherings. So happy to explain more if you come see me after the presentation. All right, please raise your hand if you are a patient with epilepsy. Awesome, me too. Welcome. We also have a adults with epilepsy support group Fridays at 5 p.m. and you can also access that online. These are all Zoom groups, but we also have a few in-person support groups, including Eric's Corner, led by Stephanie Suarez. Can you please raise your hand? Yeah, she goes to Stanford Health Care. Which one? Pleasanton? Yes. West Las Positas. All right, wait, let me give you the microphone for people who are watching online. Can you give the information for Eric's Corner, please?
The Eric's Corner in-person support group is the 3rd Thursday of every month, and it's at the
Stanford Valley Care Center on West Las Positas in Pleasanton. So we do a hybrid, so it's in person and you can also log in on Zoom. So with a total of everyone in person and online, there's about 10 of us who come in, and so it's is there food? Yes. Because it's at 5 o'clock and we know that that's around dinner time, we provide pizza for those who go in person. Sorry if you're logging in on Zoom, we don't deliver the pizza to you. Oh, yeah. Yeah, that's true. That's true. But no, you have to come in person to get the pizza. But I also run the Spanish support group, which is a Zoom one as well. And that happens on the second Tuesday of every month at 5 p.m. as well. So for anyone who prefers their first language is Spanish, but they feel that they need extra support as well, and they don't feel as comfortable coming to the adult support group, they can come at 5 p.m. log in on Zoom to speak to someone like me who speaks Spanish and help them out. And I too have epilepsy. And I can vouch for the adult support group because I started going to it many years ago. Oh, and that's how I got involved in the Epilepsy Foundation and wanted to become a volunteer here for them. So no, it's very helpful for those of you who have epilepsy. I have never been to the caregiver one, I'm not allowed there. But I have heard from caregivers that it is also extremely helpful. Also, no, they are not. Yes, we are not allowed in yours, and you are not allowed in ours. Yes, we have built boundaries for those. However, both caregivers and people who have epilepsy patients are welcome to the in-person support group because we understand that, sometimes we need more support, and to drive in person and for people who have epilepsy, like, Dr. Fisher just told us, sometimes, some people can't drive, so they would need their caregivers to help with transportation. So everyone is welcome there to the in-person one. For which one? Oh, it ranges, but it's usually about 20, 25, something like that. About 15 to 20. And it's a huge range. We even have people who come in from Oregon, there's someone from Hawaii, and they're all there just for or support or much needed support. Anything else? I mean, yeah, you can keep doing it. I'll be your improv while we're waiting for the what? When was I diagnosed? I was diagnosed when I was 14 years old. But kind of how Dr. Roberts said at the very beginning, I had been experiencing seizures for 3 years. Years beforehand, I'd had the absence seizures, which is what I called it at the time because it was such a long time ago. and I'd been having them for 3 years, but we had no idea. My family had no idea what they were. My parents thought that I was ignoring them, actually. And so when I was 14 is when I had my first grand mal tonic-clonic seizure. And so that's when I was diagnosed, and it was 17 years ago now. So yeah. 2020, back in 2020, yeah, beginning of 2020, and because it's when they went online. It's when it's when all of the support groups went online. Yeah. Did I Google it? I'm a patient at UCSF. So this is a get to know Stephanie, basically. Yeah. I'm a patient at UCSF, and one of the nurse practitioners there, Dr. Mertza Lopez, for anyone who goes to UCSF, she recommended it to me. Yeah. So, and that's where I met this one too, because at that time she had just been recently diagnosed, and she was also going to the support groups as well. Oh. And I mean, and not really. Yeah.
Okay, with or without a slide, I can do this because it's my job. So we have several events besides providing several different programs, such as support groups. We also have several walks, strolls, and runs. So if you're interested in moving your legs, please join us in a communal fashion. We just had our Seize the Moment run in March in Sacramento. How many of you went there? Anybody? Thank you, Charlie. It was a race, but there was also people who didn't race. It's just a nice place to get together. Then in April, we had our Walk for Epilepsy, which, how many of you guys joined to that? Okay, there we go. Nice to see everybody back again. And then we are about to have our stroll in June. June 15th, we're going to the zoo. And we're going to have a wild time at the zoo. Typically, it's more geared towards families and kids, but I would say there's plenty of room for anyone who wants to join. We typically go to the zoo and take a long walk around and then eat, burgers and fries and zoo food. But it's pretty enjoyable. We also have camp, both for kids and families. Has anybody here heard of Camp Coelho before? Yeah, so I'm not sure if anyone has any family members under the age of 18, specifically 9 to 18, because they can attend a camp just for kids with epilepsy. Now that's pretty special because kids oftentimes never meet another person with epilepsy or another kid. So it's a good place for kids to just meet each other and kind of have that community that'll last a whole lifetime. It's honestly a lot of kids' favorite experience. So I would definitely recommend if you know anybody. Yes, a rest is well deserved. Yes, please ask. Oh, wait, let me give you the mic in case anyone wants to know.
Are you still taking registration for this year?
Yes, definitely. We are still taking registration. Yesterday, I was actually just making my way through the Excel applications. So definitely still on our way. After Camp Coelho, the kids camp, we have family camp. That is open to people of all ages. And that's a camp for everybody. Pretty looking forward to it. That's August 15th, I believe, or late August. Yes, Pinecrest, Lair of the Bear. Thank you. Oh, do you want to? Here, sorry, on the spot here.
I have been in this camp, and next weekend I'm going to there for work weekend as a volunteer.
Oh, that's awesome. Thank you so much. So yeah, we've got quite a few events, and then we also have our gala that will be happening, I believe, November 8th. Is that correct? Yeah, pretty sure. Don't mark your calendar quite yet. And then I want to talk a little bit more about the other programs we have. I think we just mentioned support groups, but we also offer some skills courses. I know hopscotch was mentioned before. We're currently just directing people who want to take that to certain places that do offer it, but we also are trained in Project Uplift. Does anyone know what I'm talking about here? Okay, good. Got something to say. A lot of patients with epilepsy also have depression. So there is a specific skills course made. I think it's a 6-week or 8-week course where patients are taught not only cognitive behavioral therapy, but also mindfulness, certain meditations and techniques to use when certain intrusive thoughts are repeating and ruminating. So we're reinstating that. We're also revamping a skills course called PACES, if anyone's heard of that. It's for psychosocial development for people that are recently diagnosed with epilepsy, or not so recently, just to learn how to live life again with this new condition that you might not have had before. And anyone correct me if you have more things to add. And then the other thing that I'm revamping recently is peer-to-peer mentorship. So this is available for both caregivers and patients themselves. We link up patients who have epilepsy to other patients who have epilepsy just to talk. And this can be a whole wide range of ages. And the same thing goes for caregivers. Caregivers with a little bit more experience, raising a child with epilepsy for a while can help someone who's a little bit more new to the process. Okay, great. So I'm gonna try not to repeat myself here, and I'll run through some stuff, but there'll be some pretty pictures. All right, here we go. Support groups, topic groups. and peer-to-peer. I will talk more about the topic groups. We don't just have emotional support. We also have ways for you to further your creativity and kind of gain new insights about yourself. And I mentioned the skills and therapeutic courses, but I forgot to mention art therapy. It's very fun. People make amazing art out of that program. And then we also offer seizure first aid training to schools, firehouses, police departments, individuals. So please, I'll go through it later, but come talk to me if you're interested in seizure first aid for your local organization. We also have started Humans of the Storm, which is a blog by people with epilepsy about their own stories. Allows people to become empowered by writing their own narrative and for sharing it to others who in turn become empowered. And then we also have ample volunteer opportunities, both for programs and for events. All right, not going to repeat myself. We have Living with Epilepsy. I'm not sure if any of you know about it. Here at Stanford and at Sutter and other places, more to come. We had the run, we had the walk, we'll have the stroll, June 15th. We also have book talks. We just had one the other day. Excellent, about epilepsy, of course. We've got the children's camp and family camp. I believe family camp is a day late, should be the 15th, not the 16th. And then gala, as I mentioned before. All right, this is a huge calendar list of our support groups. Maybe we have too many support groups. I'm just joking. All right, we've got adolescent groups 11 through 18. Yes, if you want to take a picture, please do. And that QR code takes you to the support group page. So, yep, every Monday, 5 p.m. Zoom. There's about 3 or 4 kids that join. Tuesday, Spanish speakers, second Thursday, Stephanie. Oh no, it's second Tuesday. It's so funny. It's correct on the website, I promise. Wednesdays, caregivers, first and third Wednesday, 4 p.m. Zoom. Thursday, Eric's Corner, third Thursday, Pleasanton. Friday, best support group Zoom, because I enjoy it so much and I actually facilitate it. So every Friday, 5 p.m. Zoom. Sunday, I didn't mention, seniors group, ages 55 up. This is an incorrect day and time. It's actually it's second Sundays, 1 p.m. If you're interested in that, please write that down. Topic groups. We've got a writing group that's very special and independently run by someone named Yarrow Rubin, who helps people develop their sense of identity and self when it comes to writing, as well as with epilepsy. And so it's specifically geared towards people with epilepsy who enjoy writing or who aren't ready to write yet, but want to express themselves and don't quite know how to yet. And that's Tuesdays at 10 a.m. by Zoom. Fridays, when the support group stops, the fun starts. At 6:30 p.m., we turn into a vicious competitive group of people ready to play Uno. And so online, in that same Zoom group, we turn to online games, and it really brings a sense of camaraderie. And then we've only done this once so far, but I plan to bring it back for January, a craft circle. So each person in the group that wanted to do this created their own craft and mailed it to another person in the group, kind of like in a circle fashion. And we'll do the same thing in July. So if you want to join, find me. Art therapy. These are 2 real collages made by someone in art therapy. Her name's Jody, and she's amazing and clearly a really talented artist. But what I love is that she uses the word invisible evidence right there. This is a way for all of us to process kind of this really deep emotion that leads to incredible art. So there's beautiful stuff happening here, in my opinion. Next up, these are pictures from the Seize the Moment run. It was a great event, and I think there was a lot of different people who were affected by it positively. We just had the Walk for Epilepsy event. You can see Stephanie Suarez right there in the middle. She actually gave a speech at the walk as well, so thank you for doing that again. The Stroll for Epilepsy is happening on the 15th. If you want to register, please scan that QR code. It's all ready for you, or you just go on our website. All right, these are our summer camps. As I mentioned before, Camp Coelho is the kids' camp, and the family camp is, well, for families. The dates for the family camp may need to be updated, so I'll just repeat that. All right, I just want to say thank you to everyone who came here to sponsor. We really appreciate you taking the time and just representing yourself, so thank you. And thank you for attending. If you want to support or our programs or services in any way, please feel free to donate. Oh, actually, before I leave, any questions? I will. It's online. It's on the website.
I know that Eric's Corner is the in-person support group, but like, what else is kind of the defining feature of that as opposed to the other adult support group?
That's a great question. I would say that there's a different energy in each of our support groups. And with the adults support group, that's Fridays at 5 p.m., there's a bit of a looser energy, but I think people go to support groups for different reasons, you know? And maybe actually Stephanie could talk more to that aspect because she's actually the one who facilitates it.
As someone who goes to both, I would say the in-person support group definitely has kind of, like Natalia says, a different camaraderie, because as I went to the online one, and it was great to just get to talk to tons of people from everywhere and have different conversations, but getting to sit there in person, you definitely feel like you connect a lot more and have many more in-topic conversations, just in depth. Also, we're looking at having presentations and come in. I've spoken to the doctors here, and then I'm going to reach out to other professionals to see if we could have presentations come in about specific topics for the in-person one. It's a lot easier to do that in person in a room opposed to just online with Zoom. So, so it's a lot more intimate setting for the in-person one.
Thanks for answering that, Stephanie. Does anybody else have any questions before I turn it back to Dr. Sadat? All right. There you go.
Okay, well, I just wanted to thank everyone for coming. Thanks for being here in person. Thanks for coming online. We are here to support you guys. So we're happy that Stanford is getting a little bit closer to a lot of our patients in the East Bay. Please feel free to reach out to us with anything that you need. Thank you.